A very good morning, everybody. Good morning, good afternoon, Sat Shri Akal. Hope everything is fine. We can see each other. Just a moment. Yeah. Good afternoon, everybody. I hope we can see each other. हम एक दूसरे को देख सकते हैं. And we can hear. You can hear. I am audible. Everything is fine. Okay, very good. I'm getting replies that everything is fine. Let's begin our class. Fine. We completed gynecology in our last session. Today we are beginning with obstetrics. Hope everything is fine. You are preparing well, you are revising well, and you all are appearing in tests also and giving your tests with utmost dedication, efforts. You all are trying very hard. We can understand with your queries. Particularly, I can understand with the OBG questions you are asking, very logical questions. Means you understood the concepts. That's why you ask such sort of questions. So I'm feeling so happy that whatever efforts I tried, particularly in gynec part, you all understood very nicely. And your questions were up to the mark, optimum. So let's begin today's journey with obstetrics. Fine, everything is fine. You can hear. Good afternoon. Yes, yes, yes. Very nice. Good, 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 good. You can hear. Everything is fine. Wonderful. Very nice. Chalo. Let's just start. So today we are starting with placenta. Placenta, then we will discuss amniotic fluid, then we will discuss fetus, they are inside uterus, then we will revise your embryology also, little embryology, which was taught by ma'am, like amnion, chorion. Ma'am discussed till fetoplacental circulation. I asked ma'am, she said that she has discussed fertilization, then after fertilization she discussed morula, then she discussed blastocyst, then she discussed interstitial implantation of fertilized ovum, that is of blastocyst. Then she discussed primary villi, secondary villi, tertiary villi. Then she discussed development of uteroplacental circulation and fetoplacental circulation. So let's start our today's journey with obstetrics. Placenta. First of all, let me draw a ray diagram and let me show you how a placenta look like and what is the meaning of this word placenta. The placenta is like this, Placenta is in the shape of a disc. This is placenta. The shape of placenta is disc shaped. Because shape of placenta is disc shaped, this is why placenta is called discoid. It is called discoid. Why it is called discoid? Because it is disc shaped. And placenta is also called deciduate. Why this disc shaped placenta is also called deciduate? Because it sheds off after delivery. It is expelled out after delivery. Shades off means it is expelled out after delivery. This is why this is called deciduate. And the last session question, June June 2022, our exam question, FMG exam question was placenta is, and the option was hemochorial. Hemochorial. Hem means blood. Why placenta is called hemochorial also? Because it is in direct contact with blood on either side. On one side, placenta is in contact with fetal blood, and on other side, placenta is in contact with maternal blood. So this disc is in contact with blood on either side. On one side, it is in contact with fetal blood, while on other side, it is in contact with maternal blood. June 22, our exam question, FMG exam question was placenta is, and there were various options. And the correct answer was hemochorial. Why placenta is called hemochorial? Hem means blood. Our exam question. So placenta is discoid. Why this is discoid? Because it is in the shape of a disc. Why placenta is deciduate? Because it sheds off after delivery. Why placenta is called hemochorial? Because it is in contact with blood on either side. On one side in contact with fetal blood, and on other side it is in contact with maternal blood. Fine. Now let's understand few basic things. This placenta is attached on central part. Umbilical cord is attached on central part of placenta. This, and this is fetal surface of placenta, and this is maternal. If examiner gives you an image question, and if you get an image question in the form of this disc facing umbilical cord, and if the question is identify the surface of placenta, so this is fetal surface of placenta or maternal surface of placenta. This is fetal surface of placenta, a chocolate question. Why this is fetal surface of placenta? Because umbilical cord is attached to it. This is why this is fetal surface, and this is maternal surface of placenta, which is attached on uterine wall. This is uterine wall. This maternal surface is attached on uterine wall. While fetal surface, what is attached on fetal surface? Umbilical cord. One very important thing, umbilical cord is attached on which part of placenta? Whether the cord is attached on periphery of placenta or on central part of placenta. Umbilical cord is attached on central part of placenta. Clear to everyone? One more very important point. Look at these surfaces. This is fetal surface. This fetal surface is equal to maternal surface. Both these surfaces are equal in size. Can you see maternal surface enveloping fetal surface? No? Okay. Can you see fetal surface enveloping maternal surface? No. So both fetal surface and maternal surface, they are equal in size. None of them is larger, none of them is enveloping other one from opposite side. So they are equal in size, both fetal and maternal. Let's start writing our notes. Fine. Before this, let me show you image of fetal surface and maternal surface, and when I tell you, you can take a photograph also of these surfaces, and I will also give you these images. Don't worry, in our various sessions. This is the fetal surface of placenta. This one, fetal surface. How we can easily identify, if you get this image question, identify the surface of placenta, whether this is fetal or maternal? The game is very simple. It is fetal surface because what is attached on it? Umbilical cord. What is attached on this surface? Umbilical cord. So this is fetal surface. Very simple MCQ. Let me show you maternal surface also. How does maternal surface of placenta look like? This is maternal surface. Maternal surface is equal to fetal surface. Can you make out the difference? This is the fetal surface and fetal surface is shiny gray in color. Let me label the surface. This is fetal surface. What is the color of fetal surface of placenta? Shiny gray. What is the color of maternal surface of placenta? Color of maternal surface of placenta is dull red. This is dull red in color. So maternal surface is dull red in color while fetal surface is shiny gray in color. We very simply and very easily understood how to identify fetal surface. Umbilical cord is attached on it. While on fetal surface, there are various polygonal areas. These are these polygonal areas. Polygonal areas on maternal surface. And these polygonal areas on maternal surface, these are called cotyledons. So cotyledons are present on which surface of placenta? Cotyledons are present on maternal surface of placenta, while umbilical cord is attached on fetal surface of placenta. So this is how we can identify maternal and fetal surface. If you want, you can take a photograph of these or I will also give you photograph of these. Don't worry. So this is maternal surface of placenta and this is fetal surface of placenta. Very simple to differentiate. Let's write down the notes. Placenta is formed by two components, maternal component and fetal component. What is the color of this maternal component? This is dull red in color. It constitutes 1/5 part of placenta. Only 1/5 part of placenta is formed by maternal component. And this is formed by maternal component of placenta is formed by decidua basalis. It is formed by decidua basalis. And what is present on maternal surface of placenta? Cotyledons are present on maternal surface of placenta. These cotyledons are also called lopules. These are functional unit of placenta. These cotyledons are functional unit of placenta. Let's complete this maternal one. What is the functional unit of placenta? Functional unit of placenta are these cotyledons, which are also called lopules. So cotyledons are also called lopules and these are functional unit of placenta. Important single liner question. While fetal component, it is shiny gray in color. It constitutes 4/5 part of placenta. 4/5 portion of placenta is formed by fetal component. And fetal component of placenta is formed by chorion frondosa. They have been discussed in embryology. It is formed by chorion frondosa. And what is attached on fetal surface? Umbilical cord. Umbilical cord is attached on fetal surface of placenta. So placenta is formed by two components. This disc is formed by two components. This is fetal component where umbilical cord is attached. This is the major component. 4/5 portion, 4/5 portion of placenta is formed by this chorion frondosa, while 1/5 of placenta is formed by this outer component, which is maternal component, which is formed by decidua basalis. So this disc is composed of two components, maternal and fetal. Fetal component is towards umbilical cord. How much? 4/5 portion of placenta is formed by chorion frondosome, while outer one-fifth component of placenta is formed by decidua bacilli. Let us draw a ray diagram to understand how these are placed inside, like how placenta, fetus, umbilical cord, amnion and chorion, how they are placed inside. Let us draw a ray diagram. Let's utilize the space before this page. Let's utilize this space before this page, just a ray diagram for a basic understanding. This is uterus and this is cervix. This is the level of internal os. This is placenta. Fetal surface of placenta is formed by chorion frondosome, which constitute 4/5 part of placenta, while maternal surface is formed by decidua bacilli, which form 1/5 part of placenta. And a very important point is, there is some space behind this maternal component of placenta, and this space is called retroplacental space. A very important point, that placenta is not tightly attached on a uterine wall. It is not tightly attached on uterine wall. There is some space between placenta and uterine wall. What is this? This is uterine wall, serosa. Outermost layer of uterus, serosa. So normally there is some space between placenta and uterine wall. It means it is not tightly adhered. It is not tightly attached on uterine wall. If placenta is tightly attached on uterine wall, suppose if there is no space behind placenta and it is tightly attached on uterine wall, what may happen? After delivery of baby, once the fetus is delivered out, after delivery of baby, what may happen? Just understand. Once the baby is delivered out, baby is out. This placenta, if this placenta, suppose this is placenta and this is uterine wall. My hand is uterine wall. So this placenta will not separate from uterine wall. Why it may not separate from uterine wall? If it is tightly adhered, if it is tightly attached to uterine wall. And if it is tightly adhered to uterine wall, it is called morbidly adhered placenta. And morbidly adhered placenta is of three types: placenta accreta, placenta increta, placenta percreta, that we will discuss in this topic only, in the topic placenta. There are three types of morbidly adhered placenta: placenta accreta, placenta increta, placenta percreta. What is the cause of these? Absence of a fibrin material layer, which is called Nitabak membrane, which is present here in this space. This is why this retroplacental space is there. And if that membrane is absent, if some deposition is absent between uterine wall and placenta, placenta will be tightly attached to uterine wall and it will not separate after delivery. Nature plays a beautiful role. This is why nature has created this retroplacental space, which is due to a membrane which is called Nitabak membrane, which is the membrane of fibrin material layer. We will write everything. Don't worry. Let's start writing our notes. Fine. So, which one is the fetal component of placenta? Inner one. Where is the fetus? This is the fetus. This F is fetus. And this fetus is connected to placenta by umbilical cord. This is umbilical cord. This fetus is connected to placenta by umbilical cord. And what is the normal site of insertion of umbilical cord? We will write everything. Don't worry, just understand. Umbilical cord, everything is a single liner, important question. Umbilical cord is inserted on which part of placenta? Central part or peripheral part. It is inserted on central part of placenta. And these are the fetal membranes, amnion and chorion. The outer one is chorion and inner one is amnion. These are fetal membranes which are present inside a uterus. The outer one is chorion and inner one is amnion. Let us label these membranes also. The inner one is amnion and outer one is chorion. And what is present around this fetus? Some fluid is present around fetus. Fetus floats in a swimming pool. What is a swimming pool? The swimming pool is formed by a fluid which is called amniotic fluid. So there is a fluid surrounding this fetus. This fluid is called amniotic fluid. And this fluid prevents compression of fetus by uterine wall. If this fluid is not present around fetus, what will happen to fetus? Fetus will be compressed by uterine wall. So the purpose of this amniotic fluid is it acts as a shock absorber. It prevents compression of fetus by uterine wall. In placenta, which one is the fetal component of placenta? We know very well this inner part of placenta towards fetus, this is fetal component of placenta. And fetal component of placenta is formed by chorion frondosum. While maternal component of placenta, this is formed by decidua basilis. Color of maternal component is dull red, while color of fetal component is shiny gray. So maternal component is dull red in color, while fetal component is shiny gray in color. Of course, fetal component is towards fetus and maternal component is towards uterine wall. And normally there is a space between placenta and uterine wall. This space is called retroplacental space. Then we discuss fetal membranes, amnion and chorion, which were discussed in embryology by ma'am. Clear. This placenta, and we have made an internal os also. What is the most common location of placenta inside? Where the placenta is formed? Mostly it is formed in the lower part of uterus or in the upper part of uterus. Suppose this is uterus, so placenta is formed in upper part of uterus or in lower part of uterus. Placenta is formed in upper part of uterus. Why placenta is formed in upper part of uterus? With your embryology knowledge, you know what is the most common site of interstitial implantation. Most common site of interstitial implantation is upper posterior part of uterus. Because most common site of interstitial implantation is upper posterior part of uterus, obviously placenta will be formed in upper posterior part of uterus. So two single liner questions, same answer. And two very important questions. What is the most common site of interstitial implantation? You have written in your anatomy notes, of which T&D is also done. So you know very well. What is the most common site of interstitial implantation? Upper posterior part of uterus. So obviously, what is the most common site of placenta? Upper posterior part of uterus, because placenta will be formed obviously on the site of interstitial implantation. We will write everything. Don't worry, just understand the concept first. Clear? Let's start writing. Let's start writing our notes. Just understand with this ray diagram, although it has been discussed by ma'am about blood flow. Ma'am discussed the blood flow. Uterus is supplied by which artery? Very simple. You will say, Amit sir, why are you passing jokes on us? We are even done with T&D of anatomy. What do you think of ourselves? I think that you are prepared very well. I am just revising. Uterus is supplied by uterine artery. And uterine artery is a branch of, speak out in the room. Uterine artery is a branch of anterior division or posterior division. Uterine artery is a branch of anterior division of internal iliac artery. Just a ray diagram. You have to follow ma'am's notes of anatomy. Let me also show you a ray diagram just for that blood supply. That's just an anatomy. Although I will also cover this anatomy and all in the miscellaneous part. I will cover miscellaneous part, complete miscellaneous part. Just quickly, I will go through the anatomy also. That will be just a revision. We have included anatomy also, some part of anatomy, although it has been taken by ma'am, just for your revision. So this is uterine artery, and this uterine artery gives various branches. When it enters uterus, it enters myometrium. So branches in myometrium are arcuate artery and radial artery. This is arcuate artery and this is radial artery. These branches are present in myometrium. And then they give basal artery and spiral artery. This one is basal artery and this one is spiral artery. So basal artery and spiral artery, they supply endometrium, while arcuate artery and radial artery, they supply myometrium of uterus. What I want to say, I am not teaching you blood supply of uterus. That is anatomy, I know. I am just discussing the obstetric part. How much amount of blood is present in uterine artery, then how much amount of blood is present in uteroplacental circulation, then how much amount is present in fetoplacental circulation, and how much blood finally is received by the fetus. I am teaching you that. So before that, I am just revising your anatomy that uterine artery gives branches in myometrium. What is the name of those branches? Arcuate artery and radial artery, which then enter endometrium, and they give which branches in endometrium? Spiral artery and basal artery. Now, fine. Just tell me one thing. Tell me one thing. Let's go back to our ray diagram here. So, just a ray diagram. This is the uterine artery. It is coming here and supplying uterus, as we discussed there. Now, this uterine artery will enter uterus. It will meet placenta. It will meet placenta. So, the circulation between, just a ray diagram, all those villi, primary, secondary, tertiary, has been explained by ma'am, has been discussed by ma'am. Just a ray diagram, this uterine artery, when enter placenta, this circulation will be called utero-placental circulation. Between uterus and placenta means utero-placental. Okay, ji? Then, when these blood vessels, they are entering fetus, this circulation between placenta and fetus will be called feto-placental circulation. Very simple, no rocket science. So uterine artery, when reach placenta, this circulation is called utero-placental. Then blood vessels from placenta, they are reaching fetus. This circulation will be called feto-placental circulation, and finally this blood will reach fetus. So fetus is receiving blood. How much blood is received by fetus? Let's start writing these single liner questions, statistical question. Maximum blood should be present at which place? Uterine artery. Maximum blood should be present in uterine artery. See, what is the Gangotri? What is the main river? What is the source of blood? The main source of blood to the fetus is uterine artery. So who is the Gangotri of this Ganga? Who is the origin of this Ganga, of this river? Uterine artery. So maximum amount of blood flow will be present in uterine artery. Maximum amount of blood flow is present in uterine artery. Then little less will be present between uterus and placenta, uteroplacental circulation. Then further less will be between placenta and fetus, fetoplacental. And finally, less blood is received by fetus. GST is deducted at every step. So finally, it is reducing because these tissues also need blood, you know. What is this GST? These tissues also need blood for their survival. Why they are sitting here, working day and night? They also need some GST, you know. They also need some time. So, uterine blood flow at term. Uterine blood flow at term is 750 ml per minute. Important single liner question. Then uteroplacental circulation. It is established by approximately day 11 to 12 post fertilization. It is established by approximately day 11 to 12 post fertilization, means after fertilization. We will write all the days as post fertilization day, means this event is happening how many days after fertilization. This is post fertilization, no rocket science. At term, this uteroplacental circulation is 500 to 750 ml per minute. Again, a single liner question. Then, between placenta and fetus, fetoplacental circulation. There are two questions. It is established by what time? It is established by day 17 to day 21, post fertilization. All the days are post fertilization days. And how much it is at term? What is the meaning of word term? You may be asking, sir, you are saying term. What is this term? Term, beta, term means term pregnancy. Term pregnancy. What is this term? Let me tell you. Although you know with your pediatrics knowledge, what is the early term? We will write all this in our notes also in the topic pregnancy. Has been discussed in pedia also. Early term is 37 weeks to 38 weeks 6 days. What is term? 39 weeks to 40 weeks 6 days. What is late term? 41 weeks to 41 weeks 6 days. What is post term? 42 weeks onward. What is a preterm? Before 37 weeks. So these are various terminologies: preterm, early term, late term, and post term. All these are single liner questions. Why they become important questions? Because they are overlapping with two subjects, OBG and pediatric. Let's write down. Fetal blood flow at term. Finally, how much is received by fetus? 125 ml per kilogram body weight of fetus. 125 ml per kg. And how much is the rate of oxygen supply to fetus? This is 8 ml per kilogram body weight per minute. Rate of oxygen supply to fetus is 8 ml per kg per minute. All these are statistical questions, and I told you maximum amount has to be present in the Gangotri. The origin is uterine artery 750. Then some GST deducted, uteroplacental 500 to 750. Then further reduced in fetoplacental 400. And finally, fetus is receiving its small share 125 ml per kg body weight. Shape of placenta. Shape of placenta, we have discussed. The shape of placenta is which shape? Disc shape. Because it is disc shaped, it is called discoid. Placenta is called discoid. Simple question. What is the circumference of this? How much is the circumference of this disc? Circumference of this disc is 15 to 20 centimeter. How much is the thickness of this disc? This thickness. Thickness of this disc means thickness of this disc. This is thick, you know. This placenta is thick. One is fetal surface, which is towards fetus. Fetal surface is towards what? Fetal surface is towards fetus. And maternal surface is towards uterine wall. So this disc is thick, you know. How much is the thickness of this disc? We know that 4/5 portion, 4/5 part of this disc is formed by what? This is formed by fetal component. While 1/5 part of this disc towards outer side is formed by maternal component, which is decidua basilis. So how much is the thickness of this disc? Very simple to remember, you know. How to remember? Thickness of this disc in centimeter correspond to gestational age in weeks. Means at 20 weeks it is 2 centimeter. At 30 weeks it is 3 centimeter. So at 40 weeks how much? Speak out. 4 centimeter. At 35 weeks, 3.5 centimeter. At 25 weeks, 2.5 centimeter. At 28 weeks, 2.8 centimeter. So thickness of the disc in centimeter correspond to gestational age in weeks. Please be very careful. Gestational age is in weeks, not in days. And thickness is in centimeter, not in millimeter, meter or kilometer. Let's write down. Thickness of the disc in centimeter correspond to gestational age in weeks. At 40 weeks, thickness of the disc is 4 centimeter. So it is increasing by what? 1 millimeter per week. Thickness of this placental disc is increasing by 1 millimeter in 1 week or 1 day. 1 millimeter in 1 week. 27 weeks, 2.7 centimeter. 28 weeks, 2.8 centimeter. Placenta is called deciduate. Why it is called deciduate? Because it sheds off after delivery. It is expelled after delivery. This is why it is called deciduate. Important MCQ, a PYQ, June 22, our exam question. Placenta is hemochorial. Hem means blood. Why it is called hemochorial? Because it is in contact with blood on either side. It is in contact with blood on either side. On fetal side, this placenta, on fetal side, it is in contact with fetal blood. While on maternal side, it is on contact with maternal blood because this is towards uterine wall and this is towards fetus. Very simple. No rocket science. Weight of placenta. How much is the weight of placenta? Term placenta. We know term means, what is term? 39 weeks to 40 weeks, 6 days. Term pregnancy. That term is term pregnancy. Weight of a term placenta, we will write everything. How much is early term, how much is term, how much is late term. We will also write. That's written in PDF. We will also write in our notes in the topic pregnancy. Today only. Weight of placenta, term placenta, 500 grams. How much is the volume of placenta? Volume. And please listen to the lecture very carefully because tonight at 9 p.m. I will post telegram questions from the topics which I discussed today. And you know very well, I will discuss these telegram questions in tomorrow's class, which I will post today. So we will understand why and how we have committed silly mistakes in today's telegram question. And I will post at 9 o'clock. Volume of placenta is 500 ml. Term placenta, of course. Volume of term placenta is 500 ml. And out of these 500 ml, how much is present in the villi? 350 ml. And how much is present in intervillous space? 150 ml. Ma'am discussed with you villi, primary villi, secondary villi, tertiary villi. So how much is in the villi? Out of this 500, 350 is in the villi and 150 is in intervillous space. Normal location of placenta. Where it is placed. Let's see our ray diagram once again. Let's move to our ray diagram. In our ray diagram, although we have clearly written that placenta was in upper part and posterior part because most common site of interstitial implantation is upper posterior part of uterus. Let's see our ray diagram once again, this one. So this placenta is present. This is the anterior side. This is anterior side. Anterior means towards us. That is anterior. Suppose I am doing ultrasound here. So on ultrasound, this is anterior surface of uterus. And this is posterior side. Look where we have drawn placenta in our ray diagram. On anterior side or posterior side? We have drawn placenta on posterior surface of uterus in our ray diagram. That's for sure. And we have drawn placenta in upper part of uterus or in lower part of uterus. Of course, in upper part of uterus because implantation occurs in upper part of uterus. And this distance, which is between lower edge of placenta and internal os, this distance, which is between lower edge of placenta and internal os, this distance. which is between lower edge of placenta and internal os, this has to be at least 2 centimeter. Let me erase this uterine artery and now I will write. This distance has to be at least 2 centimeter. At least 2 centimeter. The distance between lower edge of placenta and internal os, it should be at least 2 centimeter. Means it is in upper part of uterus. And if lower edge of placenta is within 2 centimeter from internal os, this is called a low-lying placenta. If lower edge of placenta is within 2 centimeter from internal os, that will be called a low-lying placenta. Now placenta is in lower part of uterus. But normally placenta is in upper part of uterus, means distance between lower edge of placenta and internal os is at least how much? 2 centimeter. Let's write down. That is called normally located placenta. Normal location, most common location of placenta is in upper posterior part of a uterus. So most common location is upper posterior, which is also called fundoposterior. Upper posterior, which is also called fundoposterior. Let's write down lower edge of placenta should be at least 2 centimeter away from internal os. So lower edge of placenta should be at least 2 centimeter away from internal os. This is what happens normal. And second point is fetal surface should be equal to maternal surface. Their size is equal. So this disc, maternal surface and fetal surface, their size are equal. Fetal surface is equal to maternal surface. This is what happens normally. Various hormones are secreted by placenta. Various hormones, many hormones. Many are secreted by syncytiotrophoblasts, many are secreted by cytotrophoblasts. There is a long list. We are writing the important ones. HCG, human chorionic gonadotropin. Very important hormone, HCG, human chorionic gonadotropin. It is secreted from syncytiotrophoblasts. Very important single liner question was asked in our exam 4 years before. 2018 exam. HCG is secreted from syncytiotrophoblasts. There is a syncytiotrophoblasts, there is a cytotrophoblast. HCG is not secreted by cytotrophoblast. One option will be cytotrophoblast and examiner will try to trap you with cytotrophoblast. It is secreted by syncytiotrophoblasts, not by cytotrophoblast. And its secretion begins on what time? Its secretion begins on day 7 post fertilization. Its secretion begins 7 days after fertilization. 7 days after fertilization, and it is secreted from syncytiotrophoblasts. It doubles means increasing by 66%. Doubles is a vague word. Doubles is just a vague word. It doubles means it increases by 66% after 48 hours. Very important MCQ. HCG is the MCQ factory. How much is the doubling time of HCG? Doubling time of HCG is 48 hours. It doubles every 48 hours after every 48 hours. So secretion begins on how many days after fertilization? 7 days. Doubles after every 48 hours. After doubling every 48 hours, maximum levels of HCG, they are attained at approximately 10 weeks of pregnancy. Maximum levels of HCG, they are attained at 10 weeks of pregnancy. After doubling every 48 hours, it becomes maximum at 10 weeks of pregnancy. Important single liner question. 10 weeks of pregnancy means 70 days. 10 sevens are 70. So after 70 days of fertilization, maximum levels of HCG are seen. Then it start declining. Then it start falling. Minimum levels of HCG, because it has started declining after 10 weeks, because it is falling after 10 weeks, minimum levels of HCG are seen at 16 weeks of pregnancy. Every line is a very important single liner question. How much is the doubling time of HCG? 48 hours. Maximum levels of HCG are seen at 10 weeks. Minimum levels of HCG are seen at 16 weeks. And this HCG disappear from circulation 2 days after delivery. So it disappears from blood circulation, it disappears from blood 2 days after delivery. Sorry, 2 weeks after delivery, it disappears from blood 2 weeks after delivery. So if you test for HCG after 2 weeks of delivery, HCG will not be seen. It will not be detected. It can be detected till 2 weeks after delivery. MCQ factory, we have written whole complete life cycle of HCG, human chorionic gonadotropin. Just a ray diagram, just to tell you, this image is just telling you that fetus is connected to placenta and umbilical cord is inserted on central part of placenta. Various other hormones like estrogen, progesterone, human placental lactogen, HPL. This human placental lactogen is responsible for insulin resistance in pregnancy. Important single liner question. Which hormone is the cause of? What is the cause of diabetes in pregnancy? This human placental lactogen is cause of diabetes in pregnancy. How diabetes develops in pregnancy? Because placenta is secreting a hormone, human placental lactogen. And this human placental lactogen hormone binds with insulin receptor. This hormone binds with insulin receptors like a helmet. So insulin does not find a place to act. Insulin does not find a place for action because this hormone, human placental lactogen, which is secreted from placenta, it has occupied insulin receptor. It has covered insulin receptors like a helmet. So how the insulin will find a place for action? This is how insulin resistance is created. A very important question. What is the cause of insulin resistance in pregnancy? Human placental lactogen. In other words, what is the cause of diabetes in pregnancy? Human placental lactogen. And diabetes which develops due to pregnancy, means due to this hormone, is called gestational diabetes. Gestation means pregnancy. So what is the gestational diabetes? Gestational diabetes which is due to pregnancy. There can be a diabetes in pregnancy which is called over diabetes. Over diabetes means she was diabetic even before becoming pregnant. Means pregnancy has not done anything. She was a diabetic lady. That is called a over diabetes. And if diabetes developed due to pregnancy, this is called gestational diabetes. Then what is the cause of gestational diabetes? human placental lactogen. It will give a solid 1 mark. Important MCQ. Let's put a tick over it. Then, other hormone HCT, human chorionic thyrotropin. PEP-A is pregnancy associated plasma protein A. These are various hormones which are secreted by placenta, important ones. There is a word called luteoplacental shift. Let's write this also. Distance between lower edge of placenta and internal os should be, everyone speak out in the room. We are writing once again. Everyone speak out in the room. Distance between lower edge of placenta and internal os. Let's have a look at the ray diagram. This distance, which we have made with the green color, the distance between lower edge of placenta and internal os, it should be at least how much? 2 centimeter. And if lower edge of placenta is lying within 2 centimeter from internal os, this is called a low-lying placenta. And a low-lying placenta after the age of viability is called placenta previa. So, low-lying placenta is a nickname like a Pappu Guddu. And when Pappu Guddu is grown up, when Pappu Guddu becomes an adult, so if low-lying placenta becomes an adult, same low-lying placenta is called placenta previa. Just a change of nomenclature. What is the voting right? What is this voting age? Age of viability. After the age of viability, low-lying placenta is called placenta previa. Let's write. So this distance, it should be at least 2 centimeter. There is a word called luteoplacental shift. What is the meaning of this word luteoplacental shift? The name itself is telling everything. It is suggesting everything. Means function of corpus luteum has been taken over by placenta. Function of corpus luteum has been taken over by placenta. This is called luteoplacental shift. Write down function of corpus luteum is taken over by placenta. Function of corpus luteum is taken over by placenta. This is called luteoplacental shift. It occurs at approximately 10 to 12 weeks. So approximately at 10 to 12 weeks, function of corpus luteum is taken over by placenta. So in other words, suppose if I ask you this question in a little twisted way, how much is the life of a pregnant corpus luteum? 10 to 12 weeks. How much is the life of a pregnant corpus luteum? 10 to 12 weeks. Because after 10 to 12 weeks, its function will be taken over by placenta. So, life of a pregnant corpus luteum 10 to 12. If I ask you a question, life span of non-pregnant corpus luteum. Do you remember menstrual cycle? After degeneration, corpus luteum was called corpus albicans. And if no fertilization occurred, endometrial shedding occurred due to fall of progesterone. And she had bleeding. So how much is the life of a non-pregnant corpus luteum? It is approximately 10 to 12 days. While life of a pregnant corpus luteum is how much? 10 to 12 weeks. Life of a pregnant corpus luteum is 10 to 12 weeks. Let's understand quickly or let's revise quickly once again. Why corpus luteum does not degenerate in pregnancy? Why corpus luteum continues for so long? That is 10 to 12 weeks in pregnancy. while in non-pregnant state, corpus luteum has a life of only 10 to 12 days. Why so? Because corpus luteum secretes various hormones. Listen to me very carefully, I am revising. Corpus luteum secretes hormones estradiol, progesterone, inhibin A, and relaxin at term pregnancy. Main hormone is progesterone. In non-pregnant also, estradiol, progesterone, and inhibin A. Main hormone is progesterone. Progesterone holds endometrium. And maximum activity of corpus luteum was after how many days of ovulation? 8 days after ovulation. And maximum progesterone was also 8 days after ovulation. If ovulation has occurred, how much was it? At least 3 nanogram per ml. And once it became 3 nanogram per ml, what it started doing? It started giving negative feedback to luteinizing hormone LH. What LH was doing? LH was supporting corpus luteum. If there was negative feedback to LH, will LH be able to support corpus luteum? No. So corpus luteum started degenerating. So all the hormones secreted by corpus luteum started declining. This was menstrual cycle. Progesterone started declining. Progesterone was the main hormone secreted from corpus luteum, and progesterone was holding endometrium. Because progesterone started declining, will endometrium be holded anymore? No. This is why endometrial shedding started, which was expelled out in the form of blood by the process fibrinolysis, and she had menses. Okay, ji, fine. But after fertilization, this is not happening. There is no endometrial shedding. She is not having bleeding. She is coming to you and saying, Doctor Sahab, this time I did not have my periods. I missed my period. The first symptom of pregnancy is amenorrhea. She missed her period. Chocolate question of obstetrics. Very simple question. Why she is missing the period? What is the cause of amenorrhea? Why corpus luteum is continuing up to 10 to 12 weeks? If no fertilization occur, it dies in 10 to 12 days. Because after fertilization, ma'am taught you these syncytiotrophoblasts, cytotrophoblast in embryology. SCG is secreted from syncytiotrophoblasts. And in the menstrual cycle topic only, we have clearly written in our notes that pregnant corpus luteum is supported by HCG. After fertilization, this HCG is supporting corpus luteum. This is why corpus luteum is not degenerating. This is why corpus luteum is continuously secreting progesterone, which is continuously holding endometrium. So there is no endometrial shedding. This is why she is saying, Doctor Sahab, this time I did not have my period. And whenever a lady comes to us and saying she does not have menses, means it is primary amenorrhea or secondary amenorrhea. Secondary amenorrhea because she was having menses before, now she is not having menses. Do you remember the diagnostic protocol of secondary amenorrhea? Most common cause of secondary amenorrhea is pregnancy. So whenever a lady comes to us and say, Doctor Sahab, this time I did not have period, what is the first step? Urine pregnancy test, because most common cause of secondary amenorrhea is pregnancy. So we rule out pregnancy first. And what is the cause of amenorrhea? Pregnant corpus luteum is supported by HCG. HCG is secreted from syncytiotrophoblasts. HCG secretion begins after how many days of fertilization? 7 days post fertilization. So we are very clear how much is the life of pregnant corpus luteum? 10 to 12 weeks. How much is the life of non-pregnant corpus luteum? 10 to 12 days. 10 to 12, 10 to 12. Non-pregnant days, pregnant weeks. Super duper important question for our exam. Let's write down. Fine. Put a tick. So lifespan of non-pregnant corpus luteum is 10 to 12 days, while lifespan of pregnant corpus luteum is 10 to 12 weeks. And when placenta takes over the function of corpus luteum, this is called luteoplacental shift. In other words, examiner may ask this lollipop question, chocolate question, luteoplacental shift occurs at how much time? It occurs at 10 to 12 weeks. I hope everything is going fine. I didn't receive any adverse message, means you are able to hear everything. Fine. Good. Let's write. Umbilical cord. Umbilical cord is also called funis. Another name of umbilical cord is funis. These are umbilical vessels. These are umbilical vessels. And finally, how many arteries and how many veins are there? There are two arteries and one vein. So one artery, second artery, and how many vein? There are two arteries and one vein finally. During embryological development, right umbilical vein disappears and left umbilical vein persists. So finally we have two umbilical artery and one umbilical vein. Length of this is umbilical cord, which is also called funis. And umbilical cord is in the shape of coils. These coils are called folds. These are called folds or coils. These are called folds of Hoboken. Folds of Hoboken. Loops or coils or folds. Let me show you. This is umbilical cord, and this umbilical cord is in this form. These are called coils or folds or loops. Folds of Hoboken. These are those coils which are also called loops, which are also called fold. The name of these folds is folds of Hoboken. Clear? Let's write down. Length of this umbilical cord is 30 to 100 centimeter. Some statistics have started saying that this is 30 to 70 centimeter, but put a tick on 30 to 100. Why I have written these like this? If you don't get an option 30 to 100 centimeter, then the second best answer would be 30 to 70. But the best statistics, Williams 26th edition, maintain that the length of umbilical cord is 30 to 100 centimeter. Now we have Williams 26th edition also, which is the latest one, which was just out 2.5 months before. So 26th edition also maintains that length of cord is 30 to 100 centimeter. And this connects fetus with placenta. Embryologically, this umbilical cord developed from connecting stalk. This developed from connecting stalk. There are coils which are also called folds, which are also called loops, like this. So umbilical cord is in the form of coils or folds or loop. These are called folds of Hoboken. This question was asked 4 years before in our exam. Folds of Hoboken are presented. It was a very simple question. It's a PYQ. Folds of Hoboken are present in umbilical cord. Because cord is in the form of, it is in the shape of coils. Coils are also called folds. They are also called loops. Another important question, it was asked in 2017, our FMG exam, put a tick. Single liner question, connective tissue of umbilical cord is Wharton's jelly. Let me remove this image of umbilical cord. Connective tissue of umbilical cord is Wharton's jelly. And umbilical cord is attached on which part of placenta? It is attached on central part of placenta, we know. Let's see it once again. This umbilical cord is attached on which part of placenta? It is attached on central part of placenta. Okay, let's quickly revise our ray diagram also where we have drawn it. Umbilical cord is attached on which part of placenta? Central part of placenta. Crystal clear, no rocket science. Very, very simple. Very, very simple. Ayushmann Khurrana had cut umbilical cord for the first time. Ayushmann Khurrana acted as male gynecologist in the movie. Let me share, but you will not watch the movie. You will watch after 4th of December. But I watched the movie yesterday. Ayushman Khurrana has acted as male gynecologist in the movie Dr. G. मैं कल ही देख के आया. मैं इंतजार कर रहा था. 14th को रिलीज हुआ. Movie was released on 14th, but I was taking class in Chennai on 14th. I landed Delhi 14th night, so I went immediately. First show I watched Dr. G. Ayushman Khurrana has acted very well. He has acted male gynecologist and he has performed very nicely. What are the miseries of a male gynecologist when it comes to practice and when it comes to examination of female patient? How he tackled. He wanted to become an orthopedic surgeon, ortho. And he got gynae because he missed ortho. He was not getting ortho. And in gynae, he was very repulsive, very repulsive. But after few months in the gynae, in his first year PG, there was a corridor delivery, there was the acute emergency, and in the movie it was shown that the lady just landed up in the corridor, just in the gallery of the hospital, and it was a dire emergency, and Ayushman Khurrana conducted the delivery in the gallery. And after conducting the delivery, the lady, she had given birth to two children also before, but two children died in her previous pregnancies. They could not be saved after delivery. In this delivery, Ayushman Khurrana handled the delivery very nicely and saved the child. And it was shown that Ayushman Khurrana, when went to hospital 2 days after the delivery, that lady called Ayushman Khurrana to her bed. And he showed Ayushman Khurrana that he has tied some band on the wrist of the child. Ayushman Khurrana's name was Uday Gupta in the movie, and it was written Uday on the band. And she said, in our family, we name our child on the name of God. This is why I name my child as Uday, which is your name. That turned the psyche of Ayushman Khurrana and he developed a love for gynecology that in ortho, no one would write the name of child on the name of a doctor. So this is how that was very beautifully shown in the movie, but you will watch it after 4th December, not before that. Fine. So, umbilical cord is inserted on which part of placenta? It is inserted on central part of placenta. Attached on central part. Initially, it has two arteries and two veins. Later on, right umbilical vein disappears. So finally, we have which umbilical vein? Finally, we have left umbilical vein. Finally, there are two umbilical artery and one umbilical vein. Two arteries and one vein. So which vein disappears? Right. Which vein persists? Left umbilical vein is persisting. Abnormality. Abnormality. Low-lying placenta. Abnormality number one, low-lying placenta. When do you say this placenta as a low-lying placenta? If lower edge of placenta, let's draw a ray diagram to understand. Let's draw a ray diagram. This is uterus and this is cervix. This is the level of internal os. This is the level of internal os. And that was the placenta. This is the placenta. If lower edge of placenta is within 2 centimeter from internal, if lower edge of placenta, it is within 2 centimeter from internal. Ideally, it should be at least how much away from internal os? 2 centimeter away from internal os. If lower edge of placenta is within 2 centimeter from internal os, this is called a low-lying placenta. Single liner, very simple question. And same low-lying placenta after the age of viability is called placenta previa. Fine. If lower edge of placenta is within 2 centimeter, if lower edge of placenta is within 2 centimeter from internal os, this is the low line. After age of viability, same low-lying placenta. After age of viability, same low-lying placenta is called placenta previa. Just a change of nomenclature. Another abnormality. Abnormality number 2, accessory lobe. Accessory lobe in placenta. Accessory lobe means, bhai kya ho gaya ye? What is this? We are studying just one lobe, that this is the one lobe of placenta. How many lobes? I showed you how many discs. I showed you one disc, you know. So there is one lobe of placenta. Now I am saying accessory lobe. Means there are two lobes. One more, that is called accessory lobe. This accessory lobe is of three types. Three types. Let's see. This accessory lobe is of three types. Abnormality number 1, placenta bilobata, which is also called placenta duplex or placenta bipartite. Bilobata or duplex or bipartite. What does it mean? Let's draw a ray diagram. Means there are two lobes of placenta, but these two lobes, these are of equal sized lobes. Equal sized lobes. And they are connected by blood vessels. This is called placenta bipartite or placenta duplex or placenta bilobata. Equal sized lobes which are connected by blood vessels, this is the bilobata or duplex or bipartite. Then, succenturate lobe. What is this succenturate lobe? Succenturate lobe, let me draw a ray diagram. Succenturate lobe, accessory lobe is smaller in size. Accessory lobe is smaller in size and they are connected by blood vessel. So smaller accessory. They are not equal size lobes. If accessory lobe is smaller, and of course they are connected by blood vessel. Like this. This is the image of succenturate lobe which is given in our workbook. There are two lobes. This is the main lobe and the second one, this is the accessory lobe. So a smaller accessory lobe. And these lobes, they are connected by blood vessels as we can see here. These are the blood vessels. So main lobe and accessory lobe, they are connected by blood vessel. Which placenta is this? This is succenturate placenta. What was a bipartite or bilobata or duplex? Equal sized lobe connected by vessel. Unequal lobes, smaller accessory connected by blood vessel. This is succenturate lobe or succenturate placenta. Let's discuss the third variety of accessory lobe. The third variety of accessory lobe is placenta spuria. What is this spuria? Let's understand. Spuria, again, smaller accessory lobe. This is the main lobe and this is a smaller accessory. Spuria, smaller accessory. Then what is the difference with succenturate? There is no vascular connection. Between main lobe and accessory lobe, there is no vascular connection. Spurious, अलग पड़ा हुआ है ना, अलग रखा हुआ है, अलग रखा, उसको कहते हैं spurious, अलग पड़ा, अलग थलग हो गया, spurious. This smaller accessory lobe, which is having no connection by blood vessel with the main lobe, which has no vascular connection with the main lobe. This is called spurious lobe, spuria. So what is the difference between succenturate and spuria? Succenturate, both the lobes, main and accessory, they are connected by blood vessel. While spuria, main lobe and accessory lobe, they don't have vascular connection, spuria. And what was bilobata? Equal sized lobes. Bilobata was equal sized lobes connected by blood vessel. So here again, a smaller accessory lobe. And the important MCQ zone, there is no vascular connection. No vascular connection. So there are three types of accessory lobe: placenta bilobata, bilobata or bipartite or duplex. Equal size lobes. Look here. Equal size, connected by blood vessel. Sexcentriate, unequal, connected. Spuria, unequal, not connected. Complication of all three. Complication of accessory lobes means complication of bipartite, complication of sexcentriate, complication of spuria. What is the complication of all three? Before this, let me tell you one thing. Understand carefully and try to understand what happens after delivery of a baby. After delivery of a baby is out and this placenta is inside. Once the baby is delivered out, this placenta is also expelled out. And after expulsion of placenta, once placenta is out, suppose this was uterus, this uterus will contract very nicely. Just listen to me very carefully. I am giving you a very good concept. After expulsion of placenta, this uterus will contract very nicely. And if uterus contracts very nicely, the blood vessels which are present in uterus, they will also contract. If uterus contracts nicely, blood vessels in the uterus will also contract. And if blood vessels contract in the uterus, there will not be bleeding after delivery. If by chance blood vessels in uterus they do not contract after delivery, what may be the problem? The problem may be there will be excessive bleeding out of vagina after delivery, which is called postpartum hemorrhage. Clear to everyone? Very simple. Now, if main lobe is expelled out and if some accessory lobe is retained inside uterus, because there are two lobes and we are having party, oh, placenta is out, lobe is out, we don't know there is an accessory lobe inside. And this accessory lobe, if it is present inside, it will not allow uterus to contract nicely. And if uterus does not contract nicely, what will not happen? These blood vessels which are present inside uterus, they will not contract. And if they do not contract, what will be the problem after delivery? They will bleed profusely after delivery, which will be called postpartum hemorrhage. So, what is the advantage of a nice contraction of uterus? Nice contraction of uterus prevents postpartum hemorrhage. This is why we are waiting for a good uterine contraction after delivery. Suppose a lady delivered, you are in the labor room, you are going to watch the movie, you are going to attend a marriage function, very important function, but you cannot labor room. But you cannot labor room unless you feel a nicely contracted uterus. Because unless uterus contract, there is risk of postpartum hemorrhage. And postpartum hemorrhage is most common cause of most rapid death in obstetrics. Relatives are just eating sweets outside and her boarding pass may be ready. She may be about to leave this world. PPH occurs so fast. Most common cause of most rapid death in obstetrics. So you will not leave labor room unless you feel a nicely contracted uterus. Fine. Now these blood vessels which are present in uterus, they are mainly present in middle layer of myometrium. And when uterus contracts nicely, so these blood vessels contract nicely. This phenomena is called living ligature of uterus. Living ligature, autoligation. Autoligation of blood vessels due to nice contraction of uterus. Very important MCQ of anatomy and obstetrics. Living ligature of uterus is present in which layer? Living ligature of uterus is present in middle layer of myometrium. Let's draw a ray diagram to understand the living ligature of uterus, a very, very important MCQ zone. Let's try it. Fine. Living ligature of uterus. Let me show you with a ray diagram also. Look here. This is the uterus This is uterus. Outermost surface of uterus is serosa. Innermost part is endometrium and middle part is myometrium. We know this basic anatomy. Ma'am has taught you. I will also cover in miscellaneous part. Don't worry. Muscle fibers in this myometrium, they are arranged in three layers. The outer layer of muscle fibers, these are longitudinal muscle fibers. So muscle fibers in uterus, they are arranged in three layers. Let me label them. Outer longitudinal muscle fiber. Outer layer of longitudinal muscle fiber. Inner layer of muscle fibers is circular. These muscle fibers, they are arranged in three layers. So inner circular muscle fiber and middle layer of myometrium has eight-shaped or crisscross muscle fiber. Middle layer of myometrium, it has eight-shaped or crisscross muscle fiber. Middle, eight-shaped muscle fiber. And blood vessels, they are running in this middle layer of myometrium mainly. These are blood vessels which are running in middle layer of myometrium. When uterus contract nicely, these blood vessels which are running in middle layer of myometrium, these blood vessels which are running in middle layer of myometrium, these blood vessels are ligated. This is called autoligation of these blood vessels due to nice contraction of uterus. This is called living ligature of uterus. So let me write down living ligature of uterus is present in which layer? First of all, it is present in endometrium or serosa or in myometrium. It is present in myometrium. If examiner further dissect the option, living ligature of uterus is present in which layer of myometrium? It is present in middle layer of myometrium. Living ligature of uterus is present in middle layer of myometrium. What is the advantage? Advantage of living ligature of uterus is it prevents postpartum hemorrhage. Everyone knows what is the full form of PPH. We will be writing PPH, postpartum hemorrhage, as PPH. PPH means postpartum hemorrhage. So this living ligature of uterus prevents postpartum hemorrhage. Fine. So complication of all these three, whether this is placenta bilobata or succenturiate placenta or placenta sporia, complication of all three accessory lobe is postpartum hemorrhage. And this postpartum hemorrhage is normally prevented by living ligature of uterus. This living ligature of uterus will not be established if uterus does not contract nicely. And if an accessory lobe remains inside uterus, it will prevent this nice contraction of uterus. Let's put a bar. We are done with accessory lobe. We completed all three accessory lobes. Fine. Let's close. These were accessory lobes. Now, another abnormality. Another abnormality is extracorporeal placenta. Extracorporeal placenta. What is the meaning of this word extracorporeal? Extracorporeal means some surface is extra. This is placental disc. Let's discuss first. This is placental disc. This is fetal surface of placenta because umbilical cord is attached here. And this is maternal surface of placenta. Normally, these surfaces are equal in size. These surfaces are equal in size. This is fetal surface and this is maternal surface. They are equal in size. What is the meaning of word extracorporeal placenta? Meaning of word extracorporeal, chorion, placenta means one of these surfaces is extra. Oh my God. Normally, fetal surface is equal to maternal surface, we know. Extracorporeal means some surface is extra. One surface is extra. Means size of one surface is more than other surface. That is called an extracorporeal placenta. Let's write down. Size of maternal surface is more than fetal surface. Normally they should be equal. We have already written. Now again we are repeating. Normally fetal surface is equal to maternal surface. We know the rule of K. What is the extracorporeal placenta? Extracorporeal placenta means. Meaning of word extracorporeal placenta is maternal surface is larger than fetal surface. Oh my God. Maternal surface is larger than fetal surface. This is called extracorporeal placenta, like this. Maternal surface is towards uterine wall and it is dull red in color, like this. Let me draw this diagram here. Maternal surface is towards uterine wall. It is dull red in color. This is maternal surface and this is fetal surface. Towards fetus has to be the fetal surface. Towards uterine wall has to be the maternal surface, and this placenta is connected to fetus by umbilical cord, which is inserted on central part of placenta. These extracorporeal placenta, this is of two types. What are these two types? One is circummarginate and other is circumvallate. So extracorporeal placenta, it is of two types. Meaning of word extracorporeal placenta, maternal surface is larger than fetal surface. So obviously, what is the shape of placenta? It becomes C-shaped placenta, as you can see here. This has become a C-shaped placenta. This C-shaped placenta or extracorporeal placenta, this is of two types. One is circummarginate, other is circumvallate. Let's see what is the very minor difference between circummarginate and circumvallate. Circummarginate, write down, maternal surface continues smoothly with fetal surface. Maternal surface continues smoothly with fetal surface, as you can see. This dull red was the maternal surface, which has continued smoothly with the shiny gray fetal surface. A smooth continuation of dull red maternal surface with shiny gray fetal surface. That is circummarginate. There is another variety of extracorporeal placenta, which is circumvallate placenta. What is the difference? This outer one is dull red maternal surface, while this inner one, shiny gray, is fetal surface. But there is a valve-like thickening at the junction of maternal and fetal surface. Have a look at the difference. Maternal surface is not continuing smoothly with the fetal surface. There is a valve-like thickening at the junction of maternal and fetal surface. Because of this valve-like thickening at the junction of maternal and fetal surface, this placenta is called circumvallate placenta. Vallate means valve. We can easily memorize this. याद करने का बड़ा आसान तरीका है. Whatever I am speaking in Hindi, I'm speaking in English also. So don't worry, I know in this online batch there are various students. There are few students who don't even understand single word of Hindi. And there are few students who love Hindi a lot. I know. I also love. But we will keep a balance. Whatever I will speak in Hindi, I will translate it in English. तो सर्कमवेलेट प्लेसेंटा का मतलब क्या हुआ? एक वाल्व की तरह की कोई थिकनिंग है मैटरनल और फीटल सरफेस के बीच में. There is a valve-like thickening between maternal and fetal surface, and so this is called a circumvallate placenta. While what was the circummarginate placenta? Maternal surface was continuing smoothly with the fetal surface. Let's make out the difference between the two. Maternal surface, if continues smoothly with the fetal surface, this is called circummarginate placenta. And if there is a valve-like thickening between the two surfaces, this is called circumvallate. So extracorporeal placenta means one surface is extra. What is the meaning of word extracorporeal? One surface is extra. Which surface is larger? Maternal surface is larger than fetal surface. So shape of placenta in both circummarginate and circumvallate is what shape? C-shaped placenta. Circumvallate placenta, write down valve-like thickening. Valve-like thickening is present. Valve-like thickening is present between maternal and fetal surface. Easy to memorize. Valve-like means valate. Valve-like valate. This is circumvallate. Now, what can be the complication of these two? Same way, umbilical cord is attached on fetal surface, on central part of fetal surface. We know that. What will be the complication of these two? Have a look. What's the problem? The problem with these two is, since the fetal surface is small, क्योंकि fetal surface छोटी है, बच्चे को blood की supply कम हो गई. Since the fetal surface is small, blood supply to fetus is reduced, which will result in intrauterine growth restriction, IUGR. The old word was intrauterine growth retardation. The new word is intrauterine growth restriction, IUGR. Another problem will be, one problem is IUPR because fetal surface is small. What is the other problem? Look here, on this placenta, because this has become a C-shaped placenta. Let's understand the second complication. If the shape is normal, it is a disc shape, and this placenta, it is attached on uterine wall like this, clear? So if this placenta is attached on uterine wall like this, it is not easy for it to separate during pregnancy. Of course, after delivery, it will separate. There is a retroplacental space, which is preventing its morbid utterance. That's different cup of tea. During pregnancy, since this placenta is completely on its whole surface is attached to uterine wall, it will not separate easily. But if the shape of placenta is like this, oh my God, have a look. If the shape of placenta is like this, means whole placental surface is not attached to uterine wall. What may be the problem? किसी ने पेट पे लात मार दी. If there is a blow to maternal abdomen, maybe by an animal, who is the most dangerous animal in the world, everyone knows in the world. So if there is a blow to maternal abdomen, what may happen? This placenta may be separated very easily. So second complication of extracorporeal placenta is because it can be separated easily, because it is not wholly attached to uterine wall, loosely attached. Abruptio placentae. Let's write down. Another complication is abruptio placentae. So there are two complications of extracorporeal placenta, IUGR and abruptio placentae. We have the images in our workbook. We have the image of circummarginate and circumvallate placenta. Have a look. What's happening in circummarginate? This is circummarginate. In this circummarginate insertion, you can see. This is the maternal surface, and this maternal surface is covering fetal surface. This maternal surface from outer side is covering fetal surface. So they are not equal. Maternal surface is larger than fetal surface. And the second point is this maternal surface is continuing smoothly with fetal surface. There is no valve-like thickening between maternal and fetal surface. Normally, maternal and fetal surfaces are equal. Let's have a look once again at those disc shape. This one. Normally, there is no surface which is seen covering the other one because both the surfaces are equal. None of the surface normally is seen enveloping the other one. This fetal surface here, and on this fetal surface, I cannot see maternal surface coming from any side. I cannot see. Maternal surface is not covering fetal surface. Similarly here, this is the maternal surface. I cannot see any fetal surface covering this from opposite side. No way. But look here, the difference with circumvallate placenta. We can easily see these surfaces they are covering. In this image, this is our workbook image, maternal surface is enveloping fetal surface. So this is the extracordial placenta. Now the question arises, which extracordial? Is it circummarginate or it is circumvallate? So this is circummarginate. Let's have a look at circumvallate, then we will realize what is the difference between the two. Have a look here. This is the circumvallate placenta. What is this circumvallate? Can you see? Again, maternal surface is covering fetal surface. This is maternal surface. It is covering fetal surface. But can you see this valve-like thickening here? This is that valve-like thickening which is at the junction of maternal and fetal surface. It is thickened here. This is why it is called circumvallate placenta. Circumvallate means valve-like thickening is present at the junction of maternal and fetal surface, while in circummarginate placenta, there is no valve-like thickening. Only thing is maternal surface is covering fetal surface. That's all. Another abnormality is battledore placenta. What is the meaning of this battledore placenta? This is also called battledore insertion of umbilical cord. Whether it is battledore placenta or battledore insertion of umbilical cord, it doesn't matter. Meaning of the word battledore is one. Umbilical cord is attached at placental margin. Normally, it is attached on central part of placenta. Like if it is attached on placental margin, this is the fetus here, this is placenta, and this is umbilical cord. And if this umbilical cord is not inserted on central part of placenta, instead it is inserted on margin of placenta. This is called marginal insertion of umbilical cord or battledore insertion. Door means gate. We can remember door means gate. It is inserted at the gate of placenta. It is inserted at the gate of placenta, which was the gatekeeper of endometrial cancer, by the way. Amit sir, from Obs to Gynae, why you are jumping, why you are troubling us, why you are torturing us? क्या करूं यार, मेरी आदत है, दिल है कि मानता नहीं. What was the gatekeeper of endometrial cancer? P10 gene. P10. P10. KRAS. Gene mutation in P10 and KRAS results in type 1 endometrial cancer, while gene mutation P53 results in type 2 or non-endometrioid endometrial cancer. Anyway, so this is inserted on the gate at the margin of placenta. This is called battledore placenta or battledore insertion of umbilical cord if it is inserted on placental margin. Fenestrated placenta. Fenestrated. Everyone knows the meaning of word fenestration. Fenestration means there is a hole. Means there is a hole. Look here. There is a hole here. This is called fenestrated placenta. Fenestration or a hole. Like this. This is the fenestration. Mostly this fenestration is in the central part of placenta. Mostly this fenestration is in the central part of placenta. So central part of chorionic surface is absent. It results in fenestrated placenta. Very easy to identify. If there is a hole in placenta, this is called fenestrated placenta. Very simple. If central part of chorionic surface is absent, which results in formation of a fenestration or hole in placenta. Fenestration or hole in placenta, this is called fenestrated placenta. Very simple to identify also in image question, although not very important. Placenta membranaceae. Membranaceae, oh my God. What does it mean? Thin membranous placenta occupying whole uterus. Let us see. Now, placenta is formed like a membrane only, a thin membrane. What does it mean, yaar? मतलब क्या हुआ इस बात का? Placenta is not formed like this thick disc. There is a thickness of placenta, at 30 weeks 3 centimeter, at 40 weeks 4 centimeter, at 20 weeks 2 centimeter. There is a thickness of this disc. And now we are saying by chance, placenta is formed in the form of a thin membrane like a papad, like a papad, thin membrane. So, where the placental tissue will go? It needs this much thickness, It needs this much thickness. And placenta is formed like a thin membrane. So, where this tissue will go? Obviously, this placental tissue will be spread over the entire uterus. If placenta is formed like a papad, very thin placenta, where the placental tissue will go then? Obviously, it has to be spread over entire uterus. It will occupy entire uterus. And if this placenta is occupying entire uterus, it is spread over entire uterus. So this placenta, can it be only in upper part? Or it will come in lower part also? It will occupy lower part also. And if placenta is present in lower part also, what is this called as? Low-lying placenta, which after age of viability, Guddu or Pappu has grown up, will be called placenta previa. So what will be the complication of membranous placenta, placenta previa? Okay. Not only this यार, बड़ा गड़बड़ है ये, बहुत गड़बड़ झाला है. This thin placenta spread over entire uterus formed like a thin membrane puppet. Because it is a thin membrane, this thin membrane is attached tightly to uterine wall. This thin membrane is attached tightly, not only spread over entire uterus, it is attached tightly to uterine wall. And if this thin membrane is attached tightly to uterine wall, the problem is it will not separate after delivery of baby. During delivery, first of all, this fetus will be expelled out, and after expulsion of the fetus, this placenta, it has to separate. This fetus is out, now this placenta has to separate from uterine wall. If it is attached tightly on uterine wall, it will not separate. And if it does not separate, will it be expelled out? It will not be expelled out of vagina. It will remain inside uterus. Oh my God. If it remain inside uterus, can uterus contract nicely? No, because there is something inside uterus. How uterus can contract nicely? And if uterus does not contract nicely, what will not be attained? Living ligature of uterus will not be attained, which is present in middle layer of myometrium. And if blood vessels are not autoligated, they will remain open and they will bleed profusely after delivery, which is called postpartum hemorrhage. Oh my God. So this membranous placenta can result in placenta previa and morbidly adhered placenta. Because of placenta previa, she will have frequent episodes of bleeding out of vagina before delivery, which is called antepartum hemorrhage. And because of tightly attached placenta, she will bloat profusely after delivery, which is called postpartum hemorrhage. So, this membranous placenta is associated with both antepartum hemorrhage and postpartum hemorrhage because it is associated with placenta previa and morbidly adhered placenta. Let's write the notes. Thin membranous placenta occupying whole uterus, which is associated with placenta previa and morbidly adhered placenta. Remove this word accreta. Morbidly adhered placenta can be of three types: accreta, increta, percreta. Morbidly adhered placenta is the right word. What are accreta, increta, percreta? That we will discuss in this topic only. Morbidly adhered placenta. Fine. And complications of these, because of placenta previa, there will be antenatal bleeding PV. Antenatal means before delivery. Postnatal means after delivery. Antenatal means before delivery of baby. Postnatal or postpartum hemorrhage means after delivery. Post means after. Ante means before. After delivery of baby. And this is because of morbidly adhered placenta. So, antenatal bleeding PV is because of placenta previa, while postpartum hemorrhage is because of morbidly adhered placenta. Fine. Another abnormality which is super duper important for our exam, put a tick. Filamentous insertion of cord. What is this filamentous insertion of cord? Let's draw a ray diagram here. This is placenta. This is fetus. These are amnion and chorion. This is chorion. And the inner one is amnion. Amnion is formed 10 days after fertilization. Chorion is formed 8 days after fertilization. Embryology. Umbilical cord is not inserted on placenta. Rather, it is inserted on these amnion and chorion. Umbilical cord, it is not inserted on placenta. Rather, it is inserted on fetal membranes, amnion and chorion. And from these amnion and chorion, it is reaching placenta like this. This is called filamentous insertion. Villa, big villa, you know. There are big lawns outside the building. So it is not entering directly in the building. Villa, it is a villa. Outside, umbilical cord is inserted away from placenta on fetal membrane and then it is reaching placenta. This is called filamentous insertion. Let's write down. Umbilical cord is inserted on fetal membrane, amnion and chorion. Of course, the inner one is amnion. It is inserted on fetal membrane, that is amnion and chorion, and then reach placenta. This is called filamentous insertion of umbilical cord. Okay, ji. What can be the complication of this filamentous insertion? What can be the problem due to this? Look here. If by chance, if this distance where the cord was inserted, if this distance between the cord insertion and internal os, if this is less than 2 cm, if the distance between umbilical cord insertion and internal os, if this is less than 2 centimeter, this is again a previa. But is it previa of placenta or it is previa of umbilical cord? What is coming to your mind? Is it previa of placenta or previa of umbilical cord? This is previa of umbilical cord, and umbilical cord contain blood vessel. So this is previa of blood vessel. Vessels means vasa. Thus this is previa of placenta or previa of vasa. This is previa of vasa. This is why this is called vasa previa. What is this called as vasa previa? So what may be the complication of filamentous insertion of cord? Complication of filamentous insertion of cord is vasa previa. Now tell me, what can be the complication due to this vasa previa? If umbilical cord is inserted low, within 2 centimeters from internal organ. If it is vasa previa, the problem is, look here, the problem here is, this is a uterus and this is cervix. This is internal organ. If I am doing a per vaginal examination, if I am doing PV exam, my fungus are here inside vagina, they are reaching up to internal os. In PV exam, because of my per vaginal exam, if there is rupture of umbilical vessels, because they are low, if these vessels rupture, blood will come out of vagina from these vessels. Now this blood which is coming out of vagina, it is coming from umbilical vessel. So this is fetal blood or maternal blood? This is fetal blood, of course. And if bleeding continues, there will be massive bleeding from fetus. So fetus will become hypoxic, will go in distress, and fetus may die. This is why it is very important for us to know whether this blood which is coming out of vagina is fetal in origin or maternal in origin. If we have done an ultrasound before, we have seen that umbilical cord is inserting lower down. We know this is the case of vasa previa. And if this female is bleeding, we are immediately alarmed whenever we notice any bleeding per vaginum, because we know she is having a vasa previa. This blood could be of fetal in origin. So what we do, we take out this blood which is coming out of vagina and we add alkali here. We know fetal blood is resistant to alkali. We know with our patho knowledge, HbF resistant to acid and alkali. It is resistant to alkali. So we add 10% potassium hydroxide or 1 to 5% sodium hydroxide. What will happen? If this is fetal blood, will it be denatured with addition of alkali? No, because fetal blood is resistant to alkali. Had it been maternal blood, it would have been denatured. मदर का ब्लड होता तो डीनेचर हो गया होता. HbA, adult hemoglobin, is sensitive to alkali, while HbF, fetal hemoglobin, is resistant to alkali. This is why this test is a wonderful test. Every word from this test has been asked in various exams, our exam, FMG exam, NEET PG exam, DNB, which was conducted before, INI SAT, which was conducted as AIMS before, separately AIMS, PGI, JIPMER, Pondicherry, and NIMER. It has been asked in all the exams. Every word from this test. Such an important test, single alkali denaturation test, also called as EP test. Let's write down. And how do you diagnose vasa previa? Vasa previa means if insertion of umbilical cord is low. Can vasa previa be diagnosed by single alkali denaturation test? No. That test can only tell us whether the blood which is coming out of vagina is fetal in origin or maternal in origin. But diagnosis of vasa previa can be done only by a ultrasound. Oh my God, which ultrasound? A routine normal ultrasound or a color Doppler ultrasound? Color Doppler ultrasound. Because color Doppler ultrasound shows flow of blood in blood vessel. And what do you want to see to diagnose vasa previa? Where are these blood vessels? Where is the umbilical cord attached? whether it is in upper part of uterus or in lower part of uterus. So vasa previa diagnosis is done by color Doppler ultrasound, while differentiation between fetal and maternal blood is done by Singer's alkali denaturation test, which is also called AP test. Let's write down. Fine. Complication of this filamentous insertion of umbilical cord is vasa previa. And in the vasa previa, there will be bleeding per vaginum, which is of fetal in origin. So, complication of filamentous insertion of cord is vasa previa. Vasa previa may result in bleeding per vaginum. PV means per vaginum, which is of fetal in origin. Now, diagnosis of vasa previa, two important MCQs, two different MCQs. And in the options, you will shake hand with ultrasound and Singer's test. So be careful what examiner is asking. Diagnosis of vasa previa is best done with color Doppler ultrasound. Which ultrasound? Color Doppler ultrasound. Because color Doppler ultrasound shows flow of blood in the vessels. Next MCQ, differentiation between maternal and fetal blood. It is done by which test? Name of the test is Singer's alkali denaturation test. Singer's alkali denaturation test, which is also called AP test. Every word from this test has been asked in various exams. I have already told you. Reagent used in this test is 10% potassium hydroxide, or you can use 1 to 5% sodium hydroxide also. The concept is alkali has to be used. Most commonly we are using 10% potassium hydroxide. Alkali has to be. They have even asked which reagent is used in the test. They have even asked what is the principle of the test. Principle of the test is that HbF means fetal hemoglobin is resistant to alkali. We will take a break after 2 hours. So we are almost on the verge of completing 2 hours. Don't worry, we will take break after 2 hours. Principle of the test is HbF is resistant to alkali. Fetal hemoglobin is resistant to alkali. And before taking a break, just want to ask you few things, just want to share few things only in 1 or 2 minutes. Time is precious, I know. Your time, not mine. Your time is very precious. You all are revising for the test. Every 2 days, we are having a subject-wise test. And at the same time, there are ongoing classes as well. I told you before also, the whole day class can be revised quickly in 2 to 3 hours. Whole day class. The revision has to be very quick. It should not be very slow like सत्यनारायण की कथा पढ़ने बैठते. सत्यनारायण की कथा पढ़ने नहीं बैठते. It should be quick revision. Revision has to be very quick. We have to scroll the pages fast. We have to turn the pages quickly. And the best secret to do a fast revision is attend the class attentively. Listen to the class very attentively with good concentration. If you are very attentive while listening the class, almost 100% is absorbed. First of all, the class has to be absorbed. Then it has to be retained. Retention is something different. Absorption is something different. When you are listening the lecture very carefully, you are absorbing it. And how to retain? The retention will depend on what you are doing after the class. Whether you are opening a Instagram, you are opening a WhatsApp unnecessarily for unnecessary text, unnecessary messages. No. What you are doing after the class, whether you are stuck in talking, maybe with your family members, maybe with your friend, say for 15 long minutes, 20 long minutes. Why? Just finish the talk in 30 seconds. I had food. Mama, I had food, I had dinner. How are you? Fine, done. We'll talk, we'll sit with them, we'll sit with our parents, we will sit with everyone for long days, many days. We will live with them only. But as of now, retention is very important. What happens as soon as we are indulged in any unnecessary, unwanted activity after listening the whole day class? We have wasted so much of time in listening the lecture. And just after the class, we have started talking, going through Insta, scrolling, playing WhatsApp, FB, Insta, talking. Everything is evaporated very fast, evaporated very fast. Make it your own. Make this OBG your OBG. Make all the subjects your subject. How to make them? Listen very carefully and then never indulge in any unnecessary, unwanted activity. Talk to your family members, friends, and relatives very quickly in 1 or 2 minutes only. And this talking has to be finished before starting the revision. During revision, there should not be any thought in your subconscious brain, oh, that I have to talk to my father, I have to talk to my mother, I have to talk to this person, I have to talk to that person, I have to talk to this baby Shona syndrome, the most deadly, the most dangerous, the most unwanted, the most undesirable syndrome is the baby Shona syndrome. Please be careful of this baby Sona syndrome. If someone is telling you that he or she loves you very much, just text him or her that I want your one kidney, I want your one lobe of liver. That person will block you and you will immediately realize what is a true love. This true love will come in front of you. If you don't get the word PASS in your exam, those baby Shona syndromes, they will not even have a look at you. If you don't get the word PASS in your exam, this word is so selfish. We are so selfish. If you realize this before the exam, still there is ample time. Still there is lot of time. Get the word PASS in your result. How to get the word PASS? To get PASS, just listen the classes very carefully, very attentively, and now the classes will be finished just after a few days. You have to revise. The quality of revision, the quality of what you are doing, the quality of the way you are studying, revising is directly proportional to your retention. It's not the quantity. Oh, I studied 15 hours, I studied 18 hours. मैं तो 20 घंटे पढ़ रहा हूं यार, मैं तो 22 घंटे पढ़ रहा हूं यार, 2 ही घंटे सोता हूं. मजाक कर रहे हो क्या? मेरे से कह दो कोई एग्जाम देना है, अगर मैं 7 घंटे 6-7 घंटे नहीं सो रहा, मैं तो एग्जाम ही नहीं दे सकता. इफ आई डोंट स्लीप एटलीस्ट 6 to 7 hours, I can't even study in the day. So we all are different. As our faces are different, someone may need only 5 hours sleep, but someone needs 6 hours sleep. Someone may need a 7 hours sleep. Someone may need a 8 hours sleep. Is that person wrong? The person sleeping for 8 hours may score All India rank 1. It doesn't matter. If you sleep for 8 hours, then how you are devoting your day? Quality time, quality study, quality revision. It is not the quantity, it is the quality which matters. Let's come back and then we will take a break. Quickly, let's finish this filamentous insertion, then we will have tea. Principle is HbF is resistant to alkali. So fetal blood will be denatured or not denatured. So fetal blood is not denatured. While maternal blood will be denatured. While maternal blood will be denatured. Management of vasa previa is caesarean section. Management of vasa previa is caesarean section. Now onwards, we will be writing caesarean section as CS. CS. What is this image which is given in our workbook? This is the image of filamentous insertion of umbilical cord. Very important image question for our exam. Look here. This is umbilical cord, and this umbilical cord is not inserted on placenta. This is the placenta. This is placenta, that is umbilical cord, and umbilical cord is not inserted on placenta it is inserted away from placenta. And then this is running in fetal membranes like amnion and chorion. So this umbilical cord, this is running in fetal membranes first and then reaching placenta. This is called what? This is called filamentous insertion of umbilical cord. What is this abnormality? Filamentous insertion of umbilical cord. So what is the filamentous insertion of cord? Umbilical cord is not inserted directly over placenta, rather it is inserted away from placenta. Then it is traveling in fetal membranes and then finally reaching placenta. Very important image question for our exam also. If this image is given, identify the abnormality. This is filamentous insertion of cord. Let me label it also, and then we are taking a tea break now. This is filamentous insertion of umbilical cord. Let's take a break. This is 4:21. See you at 4:41. 20 minutes tea break. Let's see at 4:41. Welcome back. Let's begin with other abnormalities. Short umbilical cord. So, what is the short umbilical cord? How much was the normal length of umbilical cord? 30 to 100 centimeter. Normal length of umbilical cord is 30 to 100 centimeter. And if the length of cord is short, suppose this is the cord. If length of cord is very less, if the cord is very short, what is the problem? Can this fetus go down if the length of cord is less? If the length of cord is less, can this fetus go down? No, this fetus will remain up. This is called malpresentation. It will not settle in a proper presentation. The most common normal presentation is cephalic presentation. It will not settle. It will remain up. This is called malpresentation. Okay. What will happen at the time of labor? When uterus is contracting and trying to push the fetus down, will it be pushed downwards? No, because the cord is short. So failure of descent at the time of labor. If by chance a good uterine contraction comes, and because of good uterine contraction, if fetus is pushed suddenly, if fetus is pushed suddenly with a great force, what may happen? It may pull umbilical cord and placenta from uterine wall, and umbilical cord may come below presenting part. If umbilical cord comes below presenting part, what is the presenting part? Presenting part is the first part of fetus, which is about internal wall. It is presenting first. The lowermost part of fetus is presenting part. And if umbilical cord comes below presenting part, this is called cord prolapse. So what can be the complication? The complications can be malpresentation, failure of descent at the time of labor, abruptio placentae. Abruptio placentae. If the cord is too long means more than 100 centimeter. If it is more than 100 centimeter, what may happen? Obviously, it can easily come below the presenting part without any push, without any strong force, because the length of cord is too long. And if the cord comes below presenting part, this is called cord prolapse. Another complication may be because the cord is too long. Because the cord is too long, there can be numerous loops of cord around the neck, which is called cord prolapse. So, what can be the complication of long cord? Cord prolapse and cord around neck. Cord prolapse and what? Cord around neck. What are the complications of short cord? Malpresentation, failure of descent at labor, and abruptio placentae. Let's write down. Short umbilical cord, if length of cord is less than 30 centimeter. Normally it is 30 to 100 centimeter. If not, then 30 to 70. Complication of short cord is malpresentation, failure of descent at the time of labor, and abruptio placentae. These are complications of short cord. What is a long cord? Long umbilical cord, if length of cord is more than 100 centimeter. If it is not in option, then of course more than 70. We have already written normal length. When we wrote the normal length of cord, we have written these umbilical cord parameters. When we wrote these umbilical cord parameters, when we wrote the length of the cord on page number 147, just write down the mean length of cord, or Average length of cord is 55 centimeter. Average length is 55, whether it is considered 30 to 100 or 30 to 70. Mostly it is considered 30 to 100. So mean length or average length of cord is 55 centimeters. Single lineal statistical question. Long umbilical cord if length is more than 100 centimeter. What can be the complications of long umbilical cord? Cord prolapse and cord around neck. Another abnormality is single umbilical artery. Normally there are two umbilical arteries and one umbilical vein. Normally there are two arteries and one vein. Single umbilical artery if this cut section is given. Just a ray diagram again to show that umbilical cord is inserted on central part of placenta and fetus is connected with placenta with the help of umbilical cord. Just a basic orientation. Then we have these cut section of cord, normal cord. This is the normal cord, and in this cut section of cord, it is showing two arteries and one vein. So umbilical cord is a three vessel cord finally. Right umbilical vein disappears, left umbilical vein persists. Normal. This is the abnormal cord. This is cut section of umbilical cord. It is a two vessel cord in which there is one artery and one vein. One artery and one vein. So it is a two vessel cord. Just with cut section, you can identify whether this is a three vessel cord or a two vessel cord. Single umbilical artery right down may indicate chromosomal anomalies. Chromosomal anomaly. Most common chromosomal anomalies associated with single umbilical artery, they are trisomy. If it is single umbilical artery, most commonly it indicates chromosomal anomaly, which most commonly are trisomy. Put it in. Single umbilical artery, the best significance is chromosomal anomaly. May be present, may be seen with twin pregnancy, and it is seen more with black population like Africa. More in Africa. Exact explanation is not available. Maybe some nutritional deficiency. Twins also derive more nutrition. In Africa also there is nutritional deficiency. Exactly what the nutritional deficiencies are doing, maybe because of some deficiencies of folic acid and all, and because of deficiency of folic acid, there is accumulation of a abnormal chemical substance homocysteine, and because of homocysteine accumulation in blood, various free radicals are released in the blood, and these free radicals are the major source of abnormal happening in our body. Could be a reason. Just these 3 4 lines are written in Williams, even in 26th edition, nothing beyond this. Just may be seen more with twins pregnancy or with black population. Point number 3. Sometimes may be insignificant also. I have seen 6 pregnancies in which there was single umbilical artery. I followed them throughout the pregnancy with ultrasound, and these babies are still jumping in the world. They are scoring very good marks in the class. I am well connected to the family. Those babies are doing very fine who were born out of single umbilical artery. So sometimes they may be insignificant also. But best is we have already put a tick single umbilical artery. The best answer would be may indicate chromosomal anomalies to solve the MC. Another abnormality is morbidly adhered placenta. This morbidly adhered placenta, it can be placenta accreta, it can be increta, it can be percreta. What is a normal placentation, you know? Just see what is normal placentation. Look here with these gross ray diagrams. In this image, we have shown a normal placentation. Means this P is placenta. This P is placenta. So this is the placenta here. This is the placenta here. This is placenta here. Let me erase this and let me make it shiny gray. This is the placenta here. This is placenta. This is placental tissue. This is normal placenta. What is the morbidly adhered placenta? Morbidly adhered placenta is of three types: placenta accreta, placenta increta, placenta percreta. Accreta is, it is just attached to myometrium. Look here, see the difference. This was a normal placenta. It is not at all attached to myometrium. It was in endometrium only. While this placenta, as you can see, this is attached to myometrium like this. Can you see? This is attachment of placenta to myometrium. Accreta means attached to myometrium. While increta means it is invading myometrium. Increta means invade myometrium. While percreta means it is reaching up to outermost surface of uterus, serosa. So we have three types of morbidly adhered placenta: placenta accreta, placenta increta, and placenta percreta. Very easy to memorize also. Accreta means A, attached to myometrium. We will write all the notes. Just understand here. We will write the notes. Accreta means attached to myometrium. A accreta, A means attached. Increta means invade myometrium. Let me erase this. Now you have a look. Increta means invade myometrium. Increta. Increta means invade myometrium. Like this. Invasion in myometrium. Percreta means reaching up to outermost layer of uterus, serosa. And accreta was just attached to myometrium, not to endometrium. If it is in endometrium, this is a normal placenta. If it is start getting attached to myometrium, accreta, A attached. If it is invading myometrium, increta invades myometrium. Increta. Percreta reaches up to serosa. So which one is most dangerous type of morbidly adhered placenta? Most dangerous type of morbidly adhered placenta, of course, is percreta, where it is reaching up to outermost surface of uterus, while least dangerous type of morbidly adhered placenta is placenta accreta, where it is only attached to myometrium. Let's write down. Morbidly adhered placenta, how does it develop? Let me show you one normal thing. Normally what happens? This is decidua bacillis, which is dull red in color. This is chorion frondosum, which is shiny gray in color. Let's label this chorion frondosum. And this is decidua bacillis. So decidua bacillis form maternal component of placenta, while chorion frondosum form fetal component of placenta. We know this. Decidua bacillis form maternal component of placenta, while chorion frondosum form fetal component of placenta. Normally, there is deposition of a fibrin material layer between decidua bacillis and chorion frondosum. This fibrin material layer is deposited normally between decidua bacillis and chorion frondosum. Name of this fibrin material layer is Netabach membrane. This is a fibrin material layer. This is a fibrin material layer which is deposited between decidua bacillis and chorion frondosum. Normally it is deposited. If this fibrin material layer is absent, this fibrin material layer prevent morbid adherence of placenta. or tight attachment of placenta on uterine wall. If this Nitabok membrane is absent, placenta will be tightly attached to uterine wall. So let's write down what is the cause of morbidly adherent placenta. Cause of morbidly adherent placenta is absence of Nitabok membrane. If this Nitabok membrane is absent, which is normally present between decidobacillus and chorion fundosum, if this is absent, placenta will be tightly attached to uterine wall. This is called morbidly adherent placenta. Risk factors for morbidly adherent placenta. Most common risk factor is placenta previa. Most common risk factor is placenta previa in the ongoing pregnancy, in the present pregnancy, because this Nitabok membrane is absent in lower part. And if placenta is formed in the lower part, this membrane is deficient in lower part. And if placenta is present in lower part, if it is the case of placenta previa, very commonly it is tightly adherent. Most common risk factor for morbidly adherent placenta is placenta previa. Nitabok membrane is deficient in lower part. Other risk factors for morbidly adherent placenta. Other risk factor is history of previous lower segment cesarean section. If there is a scar in the lower segment, then placenta is tightly attached to the scar, as we have shown also in this image. This is the uterine scar. So there is a risk of tightly attached placenta with a scar. History of previous lower segment cesarean section. If there is history of any curettage, this time we will keep a 45 minutes instrument session, mandatorily a 45-minute instrument session also of obs-gynae, where we will see all the basic instruments of obs-gynae, curate and everything. So curate is a device, it is an instrument which is put in uterine cavity for the purpose of curettage. Curettage can be diagnostic curettage, therapeutic curettage, that we will discuss at that time. Just remember, if you are doing curettage, the surface, lower part of endometrium will become rough and placenta will be tightly attached. Nitabok membrane is absent in lower part. If there is history of any surgery which is involving uterine cavity, like history of myomectomy or history of hysterotomy. History of myomectomy or history of hysterotomy. Myoma fibroid was involving uterine cavity. So if you have done a surgery, you have done instrumentation involving endometrium, and endometrium has become rough. Types of morbidly adhered placenta. Types of morbidly adherent placenta, there are of three types. Placenta accreta. Accreta, I told you, accreta means attached. A means accreta, A means attached to myometrium. A means accreta, A means attached. A here also. Attached to myometrium. How? Let's draw a ray diagram to understand this. This was endometrium. This is outermost layer of uterus serosa, and this was myometrium, and this is endometrium. This is placenta here, and this placenta is attached to myometrium. It is not invading myometrium. It is just attached to myometrium. While placenta increta, there is in in the word increta. In the word increta. It means it invades myometrium. It invades myometrium. So there is in increta and there is in invades also. This is how we can easily remember what is placenta increta invades myometrium. What is placenta accreta attached to myometrium. Let me draw a ray diagram again. So increta means invades myometrium like this. It is invading myometrium. It has entered myometrium. While accreta was just attached to myometrium. Another variety of morbidly adherent placenta is placenta percreta. What is this placenta percreta? This variety reaches up to outermost layer of uterus, which is serosa. Reaches up to outermost layer of uterus, which is serosa. This is percreta, like this. Reaching up to outermost layer of uterus, here, outermost layer. This is percreta. So obviously, out of these three varieties, which one is most dangerous? Let's write down. This is most dangerous variety of morbidly adherent placenta. And which one is least dangerous variety of morbidly adherent placenta? Accreta. So very simple. How many types of morbidly adherent placenta? Three types. Placenta accreta, placenta increta, placenta percreta. Very simple to remember. Accreta means attached to myometrium. Increta means invade myometrium. Percreta means reaches up to outermost surface of uterus, means serosa. What can be the complication? Complication of morbidly adherent placenta, whether it is accreta or increta or percreta. The problem is these placenta, because they are tightly attached to uterine wall, it will not be separated after delivery of baby. It will not be separated from uterine wall after delivery of baby. And if this placenta remain inside uterus after delivery of baby, will uterus contract nicely? No. If uterus does not contract nicely, what will not be established? Living ligature of uterus will not be established. So blood vessels in uterus will remain open and they will bleed profusely after delivery. It is called postpartum hemorrhage. So complication of morbidly adherent placenta is postpartum hemorrhage. Let's write down. Very important MCQ zone. What is the complication of morbidly adherent placenta? This is postpartum hemorrhage, PPH, which is popularly known as PPH. Fine. What is the investigation of choice? Investigation of choice to diagnose these morbidly adherent placenta is ultrasonography. Ultrasound. What do you want to see in ultrasound to diagnose morbidly adhered placenta? Let's go back to our ray diagram. This was our ray diagram here. In this ray diagram, we understood very clearly there is a normal space behind placenta. This is called retroplacental space. Means this placenta is not directly attached to uterine wall. There is some space between placenta and uterine wall, which is called retroplacental space. And this space is due to Nitabuck's membrane. Now, how to see this with ultrasound? Let me show you placenta previa also and morbidly adhered placenta, how it is seen by ultrasound. Look here. Normally, when you are doing an ultrasound, look here how beautifully this retroplacental space is seen behind placenta. This is the placenta. Let me draw this. This is the placenta. This one. This is placenta. And you can see they are labeled here also in this ultrasound image. What is written? This is written as retroplacental plexus or retroplacental space. Can you see this is a normal retroplacental space? Let me show you, just see very carefully. This is the uterine wall, as you can make out. This is the uterine wall. And with this blue color, with this blue highlighter, I have highlighted placenta. And this is that retroplacental space which is between placenta and uterine wall. This space is normally present. So placenta is not tightly attached. So this is normal placenta. I am erasing these once again. You have a look at this now. Have a look at this. So this retroplacental, this black space on ultrasound is retroplacental space. Whenever we are doing ultrasound, we should see this black space normally behind the placenta. Normal retroplacental space which we discussed in our ray diagram. Now I am showing an image of morbidly adhered placenta. This is a morbidly adhered placenta, as you can see here. This is morbidly adhered placenta, which is beautifully marked by an arrow also. Can you see what is happening at this point, which is marked by the arrow? I am once again marking it with the arrow. As you can see, there is no retroplacental space behind this placenta. This placenta is tightly attached to uterine wall. This is a morbidly adhered placenta. How morbidly adhered placenta is diagnosed by ultrasound by the absence of retroplacental space, which appear blackish on ultrasound, means hypoechoic on ultrasound. That is absent here. This is how we diagnose. So let's write down on USG what we see to diagnose this. Absence of hypoechoic. This is the ultrasound terminology. We are done with radiology. Hypoechoic means blackish. Hyperechoic means whitish. Hypoechoic, absence of hypoechoic retroplacental space. Absence of hypoechoic normal retroplacental space. This is absent. Gold standard to diagnose, of course, is MRI. MRI is very costly, so we don't commonly do MRI. Investigation of choice is ultrasound, gold standard is MRI, and what is the complication of morbidly adhered placenta? We know very well. This is postpartum hemorrhage. Now, I will show you placenta previa also after this. Management for this condition. Management for this condition, if you know it is a case of morbidly adhered placenta, baby should be taken out by cesarean section, not the vaginal delivery. We do cesarean section. And most common cause of morbidly adhered placenta is placenta previa. Placenta is in lower part. So we do upper segment cesarean section to take out the baby, not the lower segment cesarean section. Another name of upper segment cesarean section is classical cesarean section. Classical CS is done. Followed by, you have taken out the baby by this cesarean section. But we know placenta is tightly attached. Placenta is not separated by uterine wall. So what has to be done? Followed by, you have taken out the baby by upper segment cesarean section. Now, if she is multipara, If she is a multipara lady, we request her to get done a hysterectomy. She should be ready for hysterectomy because we tell her this placenta is not coming out. It is tightly attached to uterine wall. We have taken out the baby by the cesarean, that's okay. But this placenta, which is not separated by your uterine wall, will cause excessive blood loss after delivery, postpartum hemorrhage. And you may even die because of postpartum hemorrhage. Because postpartum hemorrhage is most common cause of most rapid death in obstetrics that we will discuss in the topic postpartum hemorrhage. So if she is a multipara, we request her for total abdominal hysterectomy. Means we remove uterus and cervix. We do a total abdominal hysterectomy. But if she is a primipara, you have taken out baby by cesarean section. It is illogical in our part also to ask her, to request her for hysterectomy. She wants a baby later on. She wants future childbearing. How can we even request her that please get ready for hysterectomy? No way. Inhuman actually. So what should be done if she is a primipara, means who wants a future childbearing later on in life? What we do in the primipara, we leave placenta inside. We leave placenta inside. What we are thinking that autolysis will happen. This placenta will dissolve on its own. It will resolute on its own. Lysis will happen on its own in due course of time. Of course, she may have PPH, we know that, but she wants a baby also. So we do a cost-benefit analysis. What we do here, we give methotrexate and antibiotic to this lady. Why we give methotrexate and antibiotic if we have left placenta inside? Because if you leave placenta inside, there is a risk. This placental tissue may become malignant later on, and this is called choriocarcinoma. So methotrexate prevents malignant transformation, and methotrexate helps in lysis of placenta also. And because we have left placenta inside, there is risk of infection. So antibiotics take care of infection. So if you are leaving placenta inside, in a case of primipara, give methotrexate and antibiotic. Let me show you ultrasound images of placenta. How a placenta is seen in ultrasound. Let me show you first of all a normal image of placenta. A normal placenta. If I am doing an ultrasound, how a placenta looks like on ultrasound, by chance if this image is given. This is the placenta. Just concentrate on the screen. This is placenta. This is the lower edge of placenta, this one. This is the lower edge of placenta here. And this is the level of internal os. This is cervix. This is anterior part, we know. Towards us is the anterior part, and this away from us is the posterior part. So of course this placenta is the posterior placenta. It is on posterior wall of uterus. It is a posterior placenta and it is in upper part of placenta. If we have to diagnose whether this is a normally located placenta or a low-lying placenta, in ultrasound machine, we just measure the distance between lower edge of placenta and internal os. And obviously, I can see with subjective analysis also, although I will measure properly on ultrasound machine. This is more than 2 centimeter. So this is a normally located placenta. This is a normally located placenta and a posterior placenta. Normal. If by chance image is given, you can see this is a posterior placenta and a normal placenta. Let me show you another placenta now and let's compare these images. Fine. Let me put this image here on one side. Let me show you another one. Now you tell me which type of placenta is this? This is an anterior placenta or a posterior placenta? This, of course, is the anterior placenta. Look here. This placenta is here. This is the anterior placenta. But this placenta is reaching up to the level of internal org. So this is the anterior low-lying placenta. Let me show you another one. Look here. What's happening to this placenta? What's happening here? Look here. This is the case of posterior placenta again. This is the posterior placenta which is reaching up to this point. And this is the level of internal organ. So this is the posterior placenta which is reaching up to internal organ. So this is posterior but a low-lying placenta. This is posterior but a low-lying placenta. And the first image we saw, that was a posterior normal placenta. Second image we saw, that was the anterior placenta, low-lying placenta. When we do an ultrasound, we ask her to drink some water. This water helps us to get her urinary bladder full. And what is the advantage of a full urinary bladder? Whenever we go for ultrasound, we drink some water. Because of this drinking water, our urinary bladder becomes full. And see how beautifully this cervix is visualized. This is cervix and this is vagina. How beautifully cervix and vagina are visualized behind urinary bladder if we drink plenty of water before ultrasound. If we don't drink water before ultrasound, this urinary bladder will be collapsed. It will not create any contrast and vagina and cervix will not be visualized. So this is bladder. Any fluid in ultrasound appear black. Can you tell me what is this black fluid which is inside uterus? This is amniotic fluid. And that fluid which was outside uterus. This was anterior wall of cervix continuing as anterior wall of uterus. So urinary bladder was outside uterus. But this black fluid which is inside uterus, this is amniotic fluid. Can you tell me, by the way, what is this calcified area? This is fetal head. This is cranial wall, head of fetus, cranial wall, this structure of fetus. Calcifications, bones appear white on ultrasound. Any fluid appear black on ultrasound. So if given, we can easily identify which type of placenta is this, anterior or posterior, whether this is a normal placenta or an abnormal placenta. Let's solve the questions now. Vasa previa is complication of. Question number 1. Vasa previa is complication of. Battledore placenta. What was Battledore placenta? Not only these questions, I am saying you again, once again, and please understand the importance of solving the questions on Telegram. I am teaching you these topics today. We'll post the questions on Miss Next Telegram tonight only. You all are joined to that group. If you are solving the question, if you commit the mistake, I will discuss those questions tomorrow. So we will discuss what is the correct answer and why this is the answer. So you realize what silly mistake you have committed. So please do solve these questions on Telegram at 9 p.m. on Miss Next Telegram group. Fine. Battledore placenta if umbilical cord is inserted at placental margin. Placenta bipartite or bilobata or duplex. Two equal sized lobes connected by blood vessel. Vasa previa is not a complication of these two. Circummarginate placenta extracordial. Two types of extracordial placenta, circummarginate and circumvallate. What is the difference between circummarginate and vallate? Valve-like thickening is present in vallate. Maternal surface continues smoothly with fetal surface, circummarginate. Vasa previa is a complication of filamentous insertion of umbilical cord. And what is the complication of vasa previa? Bleeding PV, which is fetal in origin. Most common complication of succenturiate placenta. Most common complication of all three accessory lobes, whether this is succenturiate or spuria or bilobata, is postpartum hemorrhage. Uteroplacental circulation at term in ml per minute is 500 to 750. What is 400? Fetoplacental. What is 125? Fetal blood flow. What is 750? blood flow in uterine artery. Vasa previa is best diagnosed by. Vasa previa is best diagnosed by. Singer's alkali denaturation test gives us idea about whether this blood is fetal in origin or maternal in origin. Ultrasound, yes, we know diagnose vasa previa, but we are in habit of reading all the options till last word. App test with 10% QH diagnose whether the blood coming out of vagina is fetal in origin or maternal in origin. App test does not diagnose vasa previa. It tells us whether the blood coming out of vagina is fetal in origin or maternal in origin. Color Doppler ultrasound, yes, we know. So we had two options, B or D. Both had ultrasound, but vasa previa will be diagnosed best by which ultrasound? Color Doppler ultrasound, because color Doppler ultrasound shows blood flowing in the vessel. So so don't be stuck at option B. Read all the options till last word. This is why this is the quality of listening, quality of revision, quality of attending the class, and quality of solving the MCQ which matters. How and what we are going to do in the exams. Principle of app test is. What is the principle of app test? Which is Singer's alkali denaturation test, that fetal hemoglobin is resistant to alkali. HbF is resistant to alkali. Vasa previa resistant to alkali? No. Filamentous insertion of cord resistant to alkali? No. Vasa previa is resistant to alkali acid? No. Fetal hemoglobin is resistant to alkali. Amniotic fluid. What is this amniotic fluid? Just go back to our ray diagram once again. This is amniotic fluid. The fluid which is present around fetus. This is amniotic fluid. Fetus floats in this fluid. Fetus floats in this swimming pool. And what is the purpose of this fluid? This fluid prevents compression of fetus by uterine wall. So it acts as a shock absorber also. This fluid acts as a shock absorber. Amniotic fluid, this is present around fetus. It acts as a shock absorber, like this. Let me show you. If there is no fluid around fetus, this is how they are placed inside. If there is some fluid around fetus, what happens? This is uterine wall. This uterine wall will not compress the fetus. If there is no fluid around the fetus, suppose fluid is markedly reduced, this fetus will be compressed by uterine wall. So the main purpose of the fluid around fetus is it prevents compression of fetus by uterine wall. In other words, amniotic fluid acts as a shock absorber. Let's write the notes. Examiner is very much interested in, does this fluid provide any nutrition to fetus? No, it does not provide any nutrition. Write down amniotic fluid. What is this fluid? This is fluid around fetus. It prevents compression of fetus by uterine wall. It prevents compression of fetus by uterine wall. In other words, it acts as a shock absorber. Examiner is very much interested in encirculate no nutritive value. Amniotic fluid has no nutritive value. It does not provide any nutrition to fetus. Nutrition to fetus is provided by umbilical vein, blood. That is the nutrition to fetus, not the amniotic fluid. So let's be very clear. Now, what is the source of this fluid? How do we get this fluid? Source of this fluid in early pregnancy means up to 7 weeks. Up to 7 weeks of pregnancy, this is the ultrafiltrate from maternal plasma. Ultrafiltrate means diffusion from maternal plasma. Diffusion from maternal plasma. So up to 7 weeks of pregnancy, this amniotic fluid is mainly diffusion from maternal plasma. Diffusion from maternal plasma. After 7 weeks, mainly it starts after 12 weeks. So 7 to 20 weeks. 7 to 20 weeks, it is diffusion from fetal skin mainly. Diffusion from fetal skin. And after 20 weeks, put a take. This is our most important question. After 20 weeks, fetal urine is the major source of amniotic fluid. So you can get two questions. Question number one, after 20 weeks, what is the major source of amniotic fluid? What is the major contributor to amniotic fluid? Fetal urine. Question number two, overall, not after 20 weeks, overall, what is the major source of amniotic fluid or what is the major contributor to amniotic fluid? Fetal urine. Answer will be fetal urine. But now you may think, sir, you are saying that fetal urine becomes major contributor to amniotic fluid after 20 weeks. So is it like this that you want to say that fetal urine production starts after 20 weeks? No, no, no. Fetal urine production starts after 12 weeks. Another important question. Means fetal kidneys become functional at 12 weeks. But what is happening mainly till 20 weeks? Diffusion from fetal skin. Although fetal urine production becomes at 12 weeks, but it becomes major source of amniotic fluid after 20 weeks. So here we can write fetal kidneys become functional. Fetal urine production starts at 12 weeks. Fetal urine production starts at 12 weeks of pregnancy. But fetal urine becomes major source of amniotic fluid after 20 weeks of pregnancy. Because till 20 weeks, diffusion from fetal skin is a major source of amniotic fluid. How much is the turnover of amniotic fluid? This is 500 cc per hour. 500 ml per hour. And how this turnover is maintained? Fetus is swallowing amniotic fluid and micturating. Swallowing amniotic fluid and micturating. So it is maintained by fetal swallowing. Fetal urine production. What is amniotic fluid? Fetal urine. So how maintenance of urine? How urine production is maintained? Swallowing. Swallowing water. So urine production is maintained. Osmolality of amniotic fluid is 250 milliosmol per liter. Assessment of amniotic fluid is done by ultrasound machine. How it is done? We will see in couple of minutes. How do we assess amniotic fluid? Whether this amniotic fluid is normal in amount or it is decreased in amount or it is increased in amount. It is done by ultrasound. Composition of amniotic fluid. Amniotic fluid is fetal urine. Major source of amniotic fluid is fetal urine. So whatever is present in fetal urine is present in amniotic fluid. And what is the fetal urine? Whatever is excreted by fetal kidneys is amniotic fluid, that is fetal urine. Whatever fetal kidneys are excreting, that is the fetal urine. So what is excreted by kidney? 99% it is water. So amniotic fluid mainly is water. And how much are the solid component in amniotic fluid? So solid component in amniotic fluid, they are just 1%. Just 1%. They can be inorganic solids. They can be organic solids. Inorganic solids or organic solids, which are excreted by fetal kidneys. Inorganic solids which are excreted by fetal kidneys, sodium potassium chloride, these are inorganic solids. And organic solids which are excreted by fetal kidneys, urea, uric acid, creatinine. We know that. But all these, whether they are inorganic solids or organic solids, they constitute just 1% of amniotic fluid. 99% of amniotic fluid is water because fetal urine is mainly water. Ultrasound parameters. What are ultrasound parameters to assess amniotic fluid? Ultrasound parameters to assess amniotic fluid are single deepest pocket, which is also called largest or longest vertical pocket. Single deepest pocket, correct it, single deepest pocket or largest vertical pocket or longest vertical pocket. Another ultrasound parameter for assessment of amniotic fluid, whether amniotic fluid is adequate in amount or it is decreased or increased in amount, is AFI, amniotic fluid index. Another ultrasound parameter. What is this amniotic fluid index? This is summation of 4 pockets of amniotic fluid. If you sum up, if you add up 4 pockets of amniotic fluid, this is called amniotic fluid index. Now, what are these 4 pockets of amniotic fluid? We are assessing amniotic fluid with ultrasound, whether this is adequate in amount or decreased in amount or increased in amount. So, how we are assessing this amniotic fluid? For this purpose, when we are doing ultrasound like this, when we are doing ultrasound, let me show you. Let me explain. When we are doing this ultrasound, suppose she is a pregnant lady. This is a pregnant lady. This is not fetus now. This is not fetus. This is a pregnant lady. Consider this as a mother. She is lying and I am doing her ultrasound like this. So this is her abdomen. When I am doing ultrasound on her abdomen, this is my ultrasound probe and I am doing ultrasound like this. So I divide her abdomen in 4 quadrants. She is lying like this. So I divide her abdomen in 4 quadrants. Right upper, right lower. Left upper, left lower. So when I do ultrasound, I put my ultrasound like this. Vertically, I put my ultrasound vertically on her abdomen in 1 quadrant. This is how I will put my ultrasound probe in all 4 quadrants. Right upper, right lower. Left upper, left lower. Ultrasound waves will go inside. And when ultrasound waves will go inside in this quadrant, we will see amniotic fluid inside. And how the fluid is seen inside? Black colored. So we will measure the pocket of this amniotic fluid inside. 1 pocket in 1 quadrant, and we have divided abdomen in 4 quadrants. So we will measure length of this amniotic fluid pocket in 4 quadrants. And this image is given in our workbook. Let's come to the page number 1 where we started amniotic fluid. This is the image of assessment of amniotic fluid which is done by ultrasound. Let me zoom the image and now have a look. When we were doing ultrasound with ultrasound probe, we divided the abdomen in 4 quadrants. Suppose this is A, this is B, this is C, this is D. Right upper, right lower, left upper, left lower. Then we measured amniotic fluid. Amniotic fluid appear black. Look here. This is 1 pocket of amniotic fluid. This black we measured it. This is another pocket of amniotic fluid like this. We measured its length. Another pocket of amniotic fluid, we measured its length. Another pocket of amniotic fluid, we measured its length. This is how we measured 4 pockets of amniotic fluid. I am erasing. Now have a look once again. Just before erasing, let me again repeat these 2 ultrasound parameters. The largest pocket of these 3, this is called single deepest pocket. Largest of three, which is C, it is called single deepest pocket or longest vertical pocket. And if I add up these four, A plus B plus C plus D, this is called amniotic fluid index, summation of four pockets of amniotic fluid. Let's write our notes. Let me erase once again and have a look. This is how we did it. So these are four pockets, these black pockets, which we measured like this. Largest of the four, single deepest pocket or largest vertical pocket. If you add up these four, this is called amniotic fluid index. Let's write that. Summation of four amniotic fluid pockets. For example, A plus B plus C plus D. If we label them A, B, C, D, so what is amniotic fluid index? A plus B plus C plus D. Normal. How much is normal single deepest pocket? It is 2 to 8 centimeter. How much is normal amniotic fluid index? It is 5 to 25 centimeter. How much is normal amount of amniotic fluid? 200 ml to 2000 ml. Although it can't be weighed. तोल नहीं सकते इसको. Just a old parameter. Rough way. If amniotic fluid is decreased, if it is less in amount, if amniotic fluid is less in amount, if it is less in amount, it is called oligohydramnion. Oligohydramnion. What was oligomenorrhea? Delayed menses. What was oligospermia? If sperm count was reduced, that was oligospermia. And this is oligohydramnios if amniotic fluid is less. If amniotic fluid is excessive, this is called polyhydramnios. So if it is decreased, this is oligo. If it is excessive, this is poly. What are the causes of oligohydramnios? Causes of oligohydramnios. Before causes of oligohydramnios, let me just tell you what is the oligohydramnios. If it is less, so this is oligohydramnios. These indicate oligohydramnios. If SDP is less than 2 centimeter, if AFI is less than 5 centimeter, if amount is less than 200 ml. This is oligohydramnia. Because normally SDP should be 2 to 8, AFI should be 5 to 25, amount should be 200 ml to 2000 ml. If the parameters are less than these, this is called oligo. So obviously SDP less than 2, AFI less than 5, amount less than 200, this is oligohydramnia. Let's erase this. Fine. Now most common cause of mild oligohydramnia. Most common cause of mild oligohydramnios and mild polyhydramnios, they are idiopathic, unknown. Most common cause of severe oligohydramnia. What is the most common cause of severe oligo? Most common cause of severe oligohydramnios is maternal hypertension. Maternal hypertension. If mother is hypertensive, if her BP is high. In various literatures, they are writing fetal renal problems like bilateral renal agenesis. If both the kidneys are absent in fetus, of course, if kidneys are absent, urine will not be produced. But how many fetuses are born with both bilateral absence of kidney? Very less, very less. So bilateral renal agenesis is not the most common cause. If it is bilateral renal agenesis, if both the kidneys are absent, how the fetus is going to survive? What we are talking, is it a joke? Maternal hypertension. If mother's BP is high, how it is causing oligohydramnios? Let's understand. Blood supply to our organs, the basic physiology. Blood supply to organs in our body, it depends on what? There is a word called peripheral resistance. What is this peripheral resistance? Resistance offered by blood vessel wall to the flowing blood. And peripheral resistance determine diastolic blood pressure. Systolic BP is determined by cardiac output. We know that. Diastolic BP is determined by peripheral resistance. So if mother is hypertensive, particularly if her diastolic BP is high, if her diastolic BP is high, means her peripheral resistance is high. Very clear. If her peripheral resistance is high, organs in her body are receiving less blood or more blood? Less blood. So uterus is receiving less blood. Placenta is receiving less blood. So fetus is receiving less blood. So fetal kidneys are receiving less blood. So what will happen to fetal urinary output? Reduced. This is how maternal hypertension will reduce fetal urinary output. And what is amniotic fluid? Amniotic fluid is mainly fetal urine. So if mother's BP is high, what will happen to amount of amniotic fluid? It will decrease. This is how maternal hypertension is the most common cause of severe oligohydramnios. Bilateral renal agenesis is very rare, and be very careful. Unilateral renal agenesis will not cause oligohydramnios. It has to be bilateral, absence of both the kidneys. So let's write the notes. Maternal hypertension. If this is not given in option, so put 2 ticks on maternal hypertension and 1 tick on bilateral renal agenesis. If maternal hypertension not given in option, obviously then you can go for bilateral renal agenesis. Some other renal problem like a polycystic kidney disease. You know pathomedicine. You know polycystic kidney better than me. Polycystic kidneys, they are almost invariably bilateral. This is how they can cause oligo. And what is polycystic kidney? Urine production is impaired and they are usually bilateral. Another abnormal kidney, that is multicystic kidney, that is unilateral. That will not cause oligo. Polycystic kidney will cause oligo because this is bilateral. Other causes of oligohydramnios. Premature rupture of membrane. It is a topic. We will discuss this topic separately. Right now, just understand, membranes means amnion and chorion. Amnion and chorion normally rupture after complete dilatation of cervix, means after completion of first stage of labor. And if the membranes rupture even before onset of labor, this is called premature rupture of membrane. And if membranes rupture, those amnion and chorion, what will happen? If membranes rupture early, amniotic fluid will leak out, leading to its diminution inside. Fine. Postterm pregnancy. What is a postterm pregnancy? We know pregnancy 42 weeks or more than 42 weeks is postterm pregnancy. And what is the problem with postterm pregnancy? What develops 42 weeks onwards? Calcifications develop in placenta. 42 weeks onwards, calcifications develop in placenta. And if calcifications develop in placenta, what will happen to blood supply from mother to fetus? Blood supply from mother to fetus will decrease in postterm. And if blood supply from mother to fetus decrease, what will happen to blood supply to fetal kidney? Decrease. What will happen to fetal urinary production? Decrease. What will happen to amount of amniotic fluid around fetus? Decrease. This is how postterm causes oligo. Indomethacin. Indomethacin is a drug which reduces urinary output. You know this pharmacology. So if mother has taken indomethacin, what has happened to urine production? Reduce. It is passed to fetus after crossing placenta. Fetal urinary production reduce. Oligohydramnios. A very rare condition called amnion nodosum. Amnion nodosum. What is this very rare condition? Amnion nodosum. Let me show you with a ray diagram. Very rare. We know there are fetal membranes inside. The inner one is the amnion. Amnion nodosum is a condition in which nodules develop on amnion. Nodules develop on amnion. Nodules develop on amnion and these nodules absorb amniotic fluid. These nodules absorb amniotic fluid. So these nodules, this is the amniotic fluid inside. What these nodules start doing, these nodules start absorbing amniotic fluid, leading to its diminution inside. This is amnion nodosum, a very rare condition because these nodules absorb amniotic fluid, it will reduce inside. No rocket science. Triploidy. Triploidy is associated with fetal renal defect. This is why triploidy cause oligohydramnion. One trisomy also cause oligohydramnion. Otherwise, trisomies cause polyhydramnion. Most of the trisomy cause polyhydramnion. Why I will tell you after 10 minutes. This is the exception. Trisomy 13 cause oligohydramnion. What are the complications of oligohydramnion? Complications. We categorize complications of oligohydramnios in complication of early oligohydramnios and complication of late oligohydramnios. Complication of early oligohydramnios we categorize if oligohydramnios has developed up to 30 weeks of pregnancy. What happens here? Oligohydramnios has developed and fetus is just up to 30 weeks only. A small size fetus. It is just up to 30 weeks only. If it is a small size fetus, just up to 30 weeks only. So what's going to happen if oligohydramnios has developed around this small fetus? Less fluid around this small fetus, what will happen if there is less fluid? This uterine wall will compress this fetus. And if uterine wall is compressing this fetus, fetal lungs don't develop properly. This results in pulmonary hypoplasia. It results in what? Pulmonary hypoplasia because uterine wall compress chest. Most common complication of early oligohydramnios is pulmonary hypoplasia. Even if examiner remove this word early and your question is a single liner, straightforward chocolate question, most common complication of oligohydramnia. Even if the word early is removed, then also answer is pulmonary hypoplasia. Less fluid around, uterine wall comes in contact with chest of fetus and causes compression of chest. Lungs don't develop properly. This is pulmonary hypoplasia. What else may happen? If there is very less fluid around fetus, so uterine wall is close to this fetus. If uterine wall is close to this fetus, means amnion is also close to this fetus. Amnion, chorion, fetal membranes inside, they are also close to this fetus. And amnion is a very strong membrane, very strong membrane. Have you seen the kite, patang ka manja? Oh, kitna pehna hota hai, how sharp it is, the kite. So what is happening? The door, the thread of kite, how sharp it is. Amnion is like the thread of that kite, how sharp it is. So if amnion is coming in close contact with the fetus, sometimes what may happen, sometimes what may happen. Suppose this is amnion, this is fetal membrane, this is amnion, and if amnion comes close to fetus, this amnion may enclose or this amnion may compress some fetal part, maybe suppose some fetal finger. If it is compressed by amnion, amnion is a strong membrane. If some digit, suppose finger, one finger of fetus is compressed by amnion. So what will happen to blood supply to this finger? It will reduce and there will occur amputation of this finger. This is called amniotic bend sequence. This was the bend of amnion which has compressed the finger. Amniotic bend sequence. Let's write the notes. So complications of early oligohydramnios, there are two complications. One is pulmonary hypoplasia. Pulmonary hypoplasia. Other one is amniotic band sequence. What is amniotic band sequence? Just write down amnion may be wrapped around fetal part. Amnion may be wrapped around fetal part, which may lead to amputation of that fetal part. Amnion may be wrapped around fetal part, which may lead to amputation of that fetal part. This is called amniotic band sequence, which is a complication of early oligohydramnion. But put a tick on pulmonary hypoplasia and write down the most common complication of early oligohydramnios is pulmonary hypoplasia. Our exam question PYQ. In that question, examiner did not dissect it with early or late. The only question was, what is the most common complication of oligohydramnios? Answer, pulmonary hypoplasia. Late oligohydramnios. What is this late oligohydramnios? Late oligohydramnios we categorize if oligohydramnios develop after 30 weeks. This is late oligohydramnios. So it is a big fetus after 30 weeks. So what will happen if it is a big fetus after 30 weeks? Big fetus. Now this is a big fetus. Now what happens normally, if there is adequate amount of amniotic fluid, if there is good amount of amniotic fluid around the fetus, good fluid around the fetus, so this umbilical cord floats freely in the amniotic fluid. It floats freely in the amniotic fluid. It is away from fetal limbs. But if there is very less fluid around fetus, it is a big fetus, more than 30 weeks. So umbilical cord will not float freely. It is close to fetal limbs now because there is less fluid. Uterine wall is coming close to fetus. There are fair chances that this umbilical cord can be trapped with one of the fetal limb. किसी हाथ या पैर से ये दब जाएगी. It will be trapped by fetal limb. And if it is trapped by fetal limb, what will happen to blood supply to fetus? If umbilical cord is compressed by some fetal part, maybe by fetal limb, what will happen to blood supply to fetus? It will reduce. Because of reduced blood supply to fetus, fetus will become hypoxic. Fetus will go in distress. And because of hypoxia and distress, fetus will pass potty. And fetus will pass potty. Potty of fetus is called meconium. There is less fluid around. Fetus has passed potty. There are fair chances that this meconium can be aspirated by fetus. This is called meconium aspiration syndrome. So meconium aspiration syndrome is complication of late oligohydramnios. What else may happen due to late oligohydramnios? Mechanical compression may lead to congenital talipes equinovarus. Orthopedic problem, CTEP. Let's write down. Late oligohydramnios. Most common complication of late oligohydramnios is meconium aspiration syndrome. Meconium aspiration syndrome. Another problem is congenital talipes equinovarus, popularly known as CTEV. Congenital talipes equinovarus. This is popularly known as CTEV. But put two ticks on pulmonary hypoplasia. If overall no early or late is written, most common complication of oligohydramnios, very important question, pulmonary hypoplasia. What is the management for oligohydramnios? Management for oligohydramnios is, management will be done according to the cause. If hypertension is the reason, we will start an antihypertensive drug. If postpartum pregnancy is the reason, we will induce the labor and take the baby out. If rupture of membranes occurred, then we will see how much is the gestational age. It is a complete chapter we will discuss. So management will be done according to the cause. What is the cause of oligohydramnios? But if whatever the cause is, you have done an ultrasound, and if ultrasound show severe compression of fetus by uterine wall. So if you do an ultrasound, we saw how we saw amniotic fluids like this. We measure these pockets of amniotic fluid. If they are very less, if SDP is reduced, let me show you how ultrasound may show compression of fetus by uterine wall. Let us see. This is how a normal amniotic fluid look like. This is a normal amniotic fluid here. This is the amniotic fluid. This is the fetus here. If you are doing an ultrasound in longitudinal section, this is the fetal head. This is the fetal nose. This is the fetal mouth. And this is fetal spine. And this is amniotic fluid around fetus. Of course, this is fetal cranial wall. Fine. And this is fetal neck. And there is this amniotic fluid in which fetus floats. So you can see there is a fluid between fetus and uterine wall. So this is something which is normal. Normally there is a fluid between fetus and uterine wall. Now I will show you an image of severe oligohydramnios where this fetus is compressed by uterine wall. Let me show you. This fetus is severely compressed by uterine wall. There is hardly any fluid around. Can you see? Again, this image, this is the head of fetus, this is the neck, this is the abdomen of fetus, this is the spine of fetus, and this is uterine wall you can see, and there is hardly any fluid. Can you see? This fetus, this is the fetal neck, this is fetal abdomen, and it is directly compressed by uterine wall. There is no fluid on anterior side, there is no fluid on posterior side. So this fetus is sandwiched between both uterine wall, anterior and posterior. If you see ultrasound like this, there is no fluid. This fetus will die because of compression. So what has to be done? You have started an antihypertensive drug. Antihypertensive drug will take some time for action. Meanwhile, fetus may die. So what has to be done right now? Something has to be done right now. We have to instill some fluid here in this space. We want some fluid to come here. So what we will do, we will take a syringe, we will put normal saline in this syringe, and then we will inject this syringe in the amniotic cavity here, and we will push the saline here. This is called amnio infusion. This is done blindly or under ultrasound guidance. Of course, under ultrasound guidance, otherwise your needle may go directly into the fetal heart, directly into the fetal limb, directly into the fetal chest or abdomen. So under ultrasound guidance, while looking with ultrasound, where our needle is going, we inject the fluid in amniotic cavity. This is called amnio infusion. Let me show you an image of amnio infusion. How do we do this? Look here. This is how we do it. These images will not be asked in our exam. This I am showing you to explain the thing. This is the ultrasound transducer, as you can see. This is ultrasound transducer, means ultrasound probe. So we do an ultrasound, then we know fetus inside, we know the fluid inside, then we take a syringe, we load the saline in the syringe, then this needle is injected in the amniotic cavity, and we inject normal saline at body temperature. This is called amnio infusion. In the same way, if the fluid is excessive, that is the polyhydramnia, then we can take out the fluid. If you take out the fluid, that is called amniocentesis. If you infuse the fluid, that is called amnio infusion. Both are done under ultrasound guidance. So if you are injecting the fluid in amniotic cavity, this is amnio infusion. So amnio infusion is the treatment for what? Amnio infusion is the treatment for oligohydramnia. Amniocentesis is the treatment for polyhydramnios. Fine. But if USG shows severe compression of fetus, we have to do amnioinfusion. Infuse the fluid. Infuse the fluid. Normal saline at room temperature or body temperature, not at minus 35 degrees centigrade in Russia or Ukraine. If the temperature is room temperature is minus 35, you have to infuse the fluid at body temperature. Otherwise, what fetal mistake? There is some cutsy. Basic etiquettes, you are just providing some cold drink at minus 35 to fetal. How come? Follow the etiquettes. Polyhydramnios. So body temperature or room temperature. Please put a tick on body temperature. Fine. Polyhydramnios. What is the polyhydramnios? Polyhydramnios means excessive amniotic fluid. Most common cause of both mild oligohydramnios and mild polyhydramnios are idiopathic. Most common cause of both mild oligohydramnios and mild polyhydramnios are idiopathic, unknown. Most common cause of severe polyhydramnios. What was most common cause of severe oligohydramnios? Maternal hypertension. Most common cause of both mild oligo and mild poly are idiopathic. Most common cause of severe poly, I feel little handicap because these two causes, open neural tube defect and gastrointestinal defect, there is neck-to-neck fight in these two causes. It's not even 51 and 49. It's just 50.5 and 49.5. Such a big fight. So in the Lancet, which is the best medical journal in the world, these keep on changing. These ranks keep on changing. Sometimes open neural tube defect on the top, sometimes gastrointestinal defect on the top, based on the statistical reporting. Anyway, let's come to our exam. माई बच्चे मेरे बच्चों को मैं इतना परेशान नहीं कर सकता जितना लैंसेट करता है. I can't torture my loving student like a Lancet is torturing or these word literature are torturing. I have to give you the vote. As of now, today, I vote open neural tube defect better than. So put a tick on open neural tube defect. If the question is most common cause of severe poly, open neural tube defect, but believe me, it's today for December exam. Today means now for December exam. In January or February, if some word literature is drastically changed, then I may have to teach GI defect. Let us see what happens. Open neural tube defect are the most common cause, and the second most common is GI defect, gastrointestinal defect. What are these open neural tube defects? Open neural tube defect. In open neural tube defect, most common is anencephaly. In open neural tube defect, most common is anencephaly. What is the anencephaly? Everyone knows. Anencephaly means encephalon is absent. What is the meaning of word encephalon is absent? Encephalon is absent. Encephalon means brain. Brain is absent. Let me show you an anencephalic fetus also. Anencephalic fetus, a good overlap with radiology. Anencephalic fetus. Encephalon means brain. If brain is absent, you can see anencephalic fetus. This is the anencephalic fetus where this brain is absent. Can you see? We saw so good head. I showed you good head. Big head. There's no head here. Brain is absent. This is anencephalic fetus. And what is happening from this anencephalic fetus? Since the brain is absent, there occurs transudation of CSF, cerebrospinal fluid, because the meninges are open. Now the meninges are open. If the brain is absent, meninges are open, there occurs transudation of fluid from these meninges. Transudation of which fluid? Urine or cerebrospinal fluid? Cerebrospinal fluid. So in anencephaly, this is urine or CSF, which is responsible for polyhydramnia. Of course, this is cerebrospinal fluid, CSF, because what leaks out from these meninges? Urine or CSF? Amniotic fluid, otherwise it is mainly fetal urine. But in open neural tube defect, this will be CSF, which will be causing polyhydramnia. So the most common is open neural tube defect. And which open neural tube defect most commonly? Anencephaly. Anencephaly. Fine. So this is the anencephaly, most common. Another one is spina bifida aperta. Here also examiner traps us. How examiner traps us here? Look here. This is the spinal defect, which is a spina bifida. This is a spinal defect. Now what will happen if this spinal defect is not covered by skin? If this spinal defect is not covered by skin. So what happens here, if this spinal defect is not covered by skin, this CSF will leak out. It will come out. It will leak out from this defect. This is called spina bifida aperta. There is the aperture. Aperture means aperture. Aperta means aperture. There is the aperture. Why there is the aperture? Spinal defect is not covered by skin. There is another spina bifida, which is spina bifida occulta. This is a spinal defect, and if this spinal defect is covered by skin, this is skin and this is spinal defect. This is spinal defect. If a spinal defect is covered by skin, if a spinal defect is covered by skin, can CSF leak out? Here CSF cannot leak out because the defect is covered by skin. This is called spina bifida occulta. Occult means hidden. And this is spina bifida aperta, means there is an aperture. So examiner asks us a question, all of the following are causes of polyhydramnios except. So spina bifida occulta is not a cause of polyhydramnios, while spina bifida aperta is a cause of polyhydramnios. Things should be very clear. What are other causes of polyhydramnios? Other causes of polyhydramnios, multifetal pregnancy. Can you tell me how? If there are 2 fetuses, 3 fetuses, they are maturing. If there are 25 fetuses, 25 बच्चे अंदर, 25 के 25 सुसु कर रहे हैं, कितना बड़ा amniotic fluid, massive swimming pool बन गया ना? Trisomy 21 and 18, trisomy 21, trisomy 18, Down syndrome, Edward syndrome. These trisomies, they are associated with duodenal atresia. This is why they cause poly. Let's just understand in 1 minute. These are gastrointestinal defect, which are second most common cause of polyhydramnios. Gastrointestinal defect. How gastrointestinal defects will cause polyhydramnios? Let's understand first. If there is cleft lip or cleft palate of fetus or mother, fetus of course, cleft lip or cleft palate. If there is cleft lip or palate, fetus will not be able to swallow properly, and turnover of amniotic fluid is maintained by fetal swallowing. So if fetus is not able to swallow, whole fluid will remain outside, poly, come down. If it is a case of esophageal atresia, if it is esophageal atresia, whatever fluid has been swallowed will be vomited out. Come down. Duodenal atresia, same. Whatever fluid has been swallowed will be vomited out. Come down. You were discussed in anatomy. There is an abnormal condition called annular pancreas, C-shaped pancreas constricting duodenum. Whatever has been swallowed will be vomited out. Or if there is any intestinal obstruction, vomited out. So whole fluid will remain outside. This is how GI defects will cause polyhydramnios. Let's write. So cleft lip or cleft palate, of course fetal, esophageal atresia, duodenal, annular pancreas, or intestinal obstruction, all fetal, not maternal. Fine. Torch infection. Because of infection, there occur exudation of fluid. Chorioangioma of placenta. Oma means tumor. Tumor of placenta. Chorioangioma of placenta means tumor of placenta. So, leaking of fluid out of this tumor. RH incompatibility. Not only RH incompatibility, any fetal anemia. RH incompatibility also causes fetal anemia. Any fetal anemia, like non-immune hydrops fetalis, alpha thalassemia, Bartter syndrome. You know this patho. What happens in fetal anemia? Fetal hypoxia, fetus anoxia. Because of hypoxia, fetal liver is damaged. Liver is primary site of protein synthesis that we will discuss in RH. Don't worry. If protein synthesis is reduced in fetus, what will happen to colloid oncotic pressure of blood in fetus? Reduced. Because of reduced colloid oncotic pressure of blood of fetus, fluid will start escaping from intravascular compartment to extravascular compartment, resulting in hydrothorax, pericardial effusion, ascites, generalized skin edema, hydrops fetalis. Whole fetus is swollen. In RH incompatibility, whole fetus is swollen and become yellow because after degradation, hemoglobin is converted to bilirubin and bilirubin is excreted in fetal urine. This is why color of fetal urine in RH incompatibility become golden yellow. Important MCQ, we will discuss. So RH incompatibility is separate topic. Whatever we have discussed, we'll discuss in that topic. If mother is diabetic, why there is risk of polyhydramnios if she is diabetic? What's happening to her? Forget about fetus. What's happening to her if she is diabetic? Polyuria, polydipsia, we know. Why she is having polyuria, yaar? Because of osmotic diuresis in her. Why osmotic diuresis in her? Because sugar is high in her, glucose is high in her, and glucose acts as the osmotic gradient. Oh, and this glucose is transferred to fetus via placenta. So fetus also becomes hyperglycemic. So osmotic diuresis will occur in fetus also. And because of excessive urinary output, there will be polyhydramnios. Because what is amniotic fluid? Fetal urine. Clear. So these are causes of polyhydramnios. Most common cause of mild polyidiopathic, severe poly 2. Open neural tube defect and gastrointestinal defect. My vote today is with open neural tube defect, but the difference is I told you 50.5, 49.5. Examiners should refrain. They should avoid asking these kind of questions. If examiner is asking these kind of questions, let me be very honest and very clear with you. If examiners ask these kind of questions, they are not good quality examiner. A good quality examiner asks a good quality question because our goal is to create you as good quality doctor. A good quality doctor is who can treat a patient well, who can save a life when it is required. Are you going to, are they, these boards going to make you as a doctor or a clerk? As a statistician, no. You know, once long time back I told you, there was a question asked 10 years before. Pepsi smear was invented by, and you know the options? George Papanicolo, Ian Papanicolo, Mac Papanicolo, Donald Papanicolo. Arre yaar, whether it was Mac or George or Ian or Donald, will the patient die? Patient will not die. They should ask good quality questions. And good examiners always ask good quality questions. Fine. These are various causes of polyhydramnios. What is the complication of polyhydramnios? Complication. What's happening due to polyhydramnios? There is excessive amniotic fluid in her. Because of excessive amniotic fluid, what will happen? You know, what happens normally in pregnancy? Normally also in pregnancy, because of this fetus here, in abdomen, diaphragm is raised up. Diaphragm is raised up. But what will happen if it is a case of polyhydramnios? Excessive amniotic fluid. Diaphragm is raised much. And if the diaphragm is raised much, what will happen to her? She will have respiratory difficulty. And Due to excessive amniotic fluid, what will happen in her if the amniotic fluid is excessive? If the fluid is excessive, there will be more pressure. Suppose this is cervix here, this is cervix, this is cervix, and this is fetus here. If the fluid is excessive, what will happen? There will be more pressure on cervix, early pressure on cervix, cervix will dilate early, preterm labor. More pressure on membranes, amnion and chorion will rupture early, premature rupture of membrane. Massive amniotic fluid inside, fetus will go to right side or left side continuously. It will not settle in one presentation, malpresentation. And if membranes rupture, excessive amniotic fluid, if membranes rupture, there will be sudden gush of fluid out. Because of sudden gush of fluid out, a tractional force will be created and this tractional force will pull umbilical cord down. And umbilical cord is attached to placenta. If umbilical cord is pulled down, what may happen? This umbilical cord which is pulled down will lead to separation of placenta from uterine wall. So cord prolapse and abruptio placentae will occur. What else may happen? There was massive amniotic fluid, so uterus was over-distended. Uterus was overstretched because of massive amniotic fluid. And if uterus was overstretched, if a rubber band is stretched for a longer time, even from morning to evening, and this polyhydramnios is for months, and if a rubber band is stretched for a longer time, does it regain its original tensile strength? No. If it doesn't regain its original tensile strength, what's happening to tone of uterus? Tone is reduced. And if tone of uterus is reduced, will it contract nicely after the delivery? No. And if uterus does not contract nicely after the delivery, what will happen to blood vessels inside uterus? Will they be autoligated or they will remain open? They will remain open and will bleed profusely. This is called postpartum hemorrhage. So these are various complications of polyhydramnios. Respiratory discomfort, preterm labor, premature rupture of membrane, malpresentation going here and there, swinging like a pendulum, cord prolapse, abruptio placentae, and postpartum hemorrhage. Fine. What is the management of these complications? Management will be done according to the cause, depending on the cause, whatever the cause is. But if she is facing severe respiratory discomfort, she comes to you and says, Doctor, do whatever you want, but I cannot continue with this pregnancy now. I cannot continue with this pregnancy now. Do whatever you want. I cannot continue with this pregnancy. I can't tolerate this breathlessness. What can be done? We will take out the amniotic fluid from her under ultrasound guidance. And if you are taking, this is called amniocentesis. So don't be clean bold with the word infusion or centesis. Amnioinfusion is treatment of oligohydramnios, while amniocentesis is treatment of polyhydramnios. One more thing we can try, we can give her a drug, indomethacin. We know indomethacin reduces urinary production. So indomethacin is a cause of oligohydramnios, but it is treatment of polyhydramnios because it reduces urinary production. Important overlap with pharmacology, important MCQ of pharma also. This indomethacin should not be used beyond 32 weeks. This indomethacin should not be used after 32 weeks. Otherwise, it may cause premature closure of ductus arteriosus. Important MCQ of pharma, important MCQ of OBG. When you are using indomethacin for any reason in a pregnant lady, never use it after 32 weeks of pregnancy. If you use indomethacin after 32 weeks of pregnancy, it may cause premature closure of ductus arteriosus. Important. Now, color of amniotic fluid. MCQ number 1. What is the color of amniotic fluid? MCQ number 1. Answer is very simple. Colorless. If examiner does not write anything beyond it, the only question is what is the color of amniotic fluid? Answer is colorless. MCQ number 2. What is the color of amniotic fluid at term pregnancy? 39 weeks to 40 weeks, 6 days. It is straw colored, light yellow. Why it is straw colored or light yellow? It is due to skin flakes. In term pregnancy, desquamation occurs. Fetal skin flakes are floating in amniotic cavity. And what is the name of fetal skin flakes? Pediatrics. These are called vernix caseosa. Fetal skin flakes, which are floating in amniotic cavity. They indicate maturity of fetus, a mature fetus, desquamation. And because of these fetal skin flakes, color of amniotic fluid at term pregnancy, if the word term is written, answer will not be colorless. It will be light yellow. It is indicating floating fetal skin flakes in amniotic fluid. MCQ number 3. What is the color of amniotic fluid in RH incompatibility? Golden yellow, due to bilirubin. We know that. It is due to bilirubin. What is happening in fetus in RH incompatibility? Hemolysis. Hemolysis means damage of fetal hemoglobin. And after damage, hemoglobin is converted to bilirubin. MCQ number 4. In these three conditions, whether this is listeria infection, breach or transverse, meconium. Color of meconium is green. So in listeria infection also it passes meconium. Breach or transverse meconium can be seen easily if you are doing a speculum examination and trying to see the color of amniotic fluid. Breach means this potty, the podalic part, this area is near to cervix. So you can easily see this meconium. So green colored meconium has no value in breach or transverse. We know this is meconium. Abruptio placentae. In abruptio placentae means premature separation of placenta. Separate topic, we will discuss it. Color of amniotic fluid become dark. How and why? I will just discuss. In intrauterine fetal death, which is popularly known as IUFT, in intrauterine fetal demise, demise means death. In intrauterine fetal death, color of amniotic fluid become blackish brown, the classical tobacco colored. And this classical tobacco colored or blackish brown color is due to thromboplastin. Thromboplastin is a substance which is released after separation of placenta, premature separation of placenta. This thromboplastin gives brownish black color. This thromboplastin is released after placental separation also. This thromboplastin is released after placental separation also. But it is released in more amount after fetal death. This is why after fetal death it becomes classical blackish brown. While after abruptio placentae it is only dark colored. It doesn't become classical blackish brown. So dark colored or tobacco colored, they are due to thromboplastin. Amount of thromboplastin released is more after fetal death in comparison to released after separation of placenta. So in abruptio placentae, it is only converted to dark colored, while in IUFT, it gets converted to classical tobacco colored amniotic fluid. In post-term pregnancy, what is the post-term pregnancy? We know 42 or more than 42 weeks. What happens in a post-term pregnancy? Calcifications develop in placenta. And due to calcifications in placenta, blood supply from mother to fetus is reduced. Because blood supply from mother to fetus is reduced, what is happening? Fetus is receiving less blood supply. Fetus becomes hypoxic. Fetus passes meconium. And what is the color of meconium? Green. And what is the color of amniotic fluid in a term pregnancy? This is the post-term rather. Light yellow. So green meconium and light yellow of term, it becomes greenish yellow. Means saffron colored, kesar ke jaisa. So kesar ke jaisa amniotic fluid is seen in post-term pregnancy. Amount of amniotic fluid. This question was asked in last to last session in our exam. They asked the question, maximum amount of amniotic fluid is seen at. The right answer to this question, maximum amount of amniotic fluid, the right answer is 32 to 34 weeks. Between 32 to 34 weeks, it is 1000 ml, 1 liter. So overall maximum amount of amniotic fluid is 1 liter. And this is present between 32 to 34. Between 32 to 34, again these are called foolish questions, stupid questions, absurd questions. Put a tick on 32. 32 is better than 34. I will give you one supporting evidence here. Maximum fetal movements are also seen at 32 weeks. Maximum fetal movement. How fetus can have maximum movement? If the fluid around is maximum, then only fetus can do swimming properly. So maximum fetal movements are seen at 32 weeks. This is again a clue that maximum amount of amniotic fluid is seen at how many weeks? Maximum amount of amniotic fluid is seen at 32 weeks. Put it in. Answer to two questions. Oh, between 32 is 34. If it is a good examiner, he will not trap you between 32 to 34. But we were trapped. In fact, 32 was not given in option. If 32 is not given in option, I think so. Then answer has to be 34. 32 was not in option, I think. Only this will be R. All of the following are causes of oligohydramnios except chorioangioma of placenta cause poly, amnion nodosum cause oligo, triploidy cause oligo, postterm cause oligo. Because the question is except, answer is chorioangioma of placenta. Placental tumor causes polyhydramnia. So these kind of questions will be asked in our exam. All of the following are causes of oligohydramnios except, or all of the following are causes of polyhydramnios except. Most common complication of late oligohydramnios. Most common complication of late oligohydramnios is meconium aspiration syndrome. In this question, if the word is early, then answer would be pulmonary hypoplasia. If nothing is written, if the question is most common complication of oligohydramnios, then also answer will be pulmonary hypoplasia. Because in this question, especially the word late is mentioned. This is why answer is meconium aspiration syndrome. Very important, super duper important question. If the question is most common complication of oligohydramnios, answer will be pulmonary hypoplasia. Amniotic band sequence is also complication of early oligohydramnios. Postpartum hemorrhage is complication of polyhydramnios. All of the following are complications of polyhydramnios except. So these kind of questions may be asked. All of the following are causes of oligo or poly except. All of the following are complications of oligo or poly except. So complications of poly preterm labor years, postpartum hemorrhage years, pulmonary hypoplasia is a complication of oligohydramnia. Malpresentation complication of polyhydramnia. A pregnant woman, she comes for checkup at 28 weeks. Okay. Her fundal height is 24 weeks. She comes for checkup at 28 weeks. And fundal height is 24 weeks. Fundal height means we will discuss in the next topic. Fundal height next to next topic. Fundal height means if you are checking how much is the uterine height, that is corresponding to 24 weeks pregnancy. But she says she is having 28 weeks pregnancy. And ultrasound shows oligohydramnia. Means what is the cause of decreased fundal height? because the amniotic fluid is lab. Although she is 28 weeks pregnant, but uterine height is corresponding only to 24 weeks because of oligohydron. What is most likely? Means in this googly ball question, examiner is simply asking, what is the cause of oligohydron? So esophageal atresia cause poly, spina bifida occulta cause nothing, hydrops fetalis cause poly, maternal hypertension cause oligohydron. Summation of four amniotic fluid pockets in ultrasound is called. What is this? 4AF nothing. AFI, amniotic fluid index. SDP single deepest pocket. LVP longest vertical pocket. No. So if you add up 4, this is called amniotic fluid index. Let's take a break. This is 6:32. Let's see you at 6:52. 20 minutes break. Let's meet at 6:52. Welcome back. Fine. So in this topic, amniotic fluid, I think we didn't write pH. pH of amniotic fluid. We skipped this pH. How much is the pH of amniotic fluid? pH of amniotic fluid is between 7 to 7.4. On an average, it is 7.2. So pH of amniotic fluid is 7.7 to 7.4. The average is 7.2, means amniotic fluid is alkaline. pH of blood is also alkaline. pH of semen is also alkaline. So semen is alkaline, semen pH 7.2. Blood is alkaline, amniotic fluid is alkaline, and urine is acidic. Specific gravity of amniotic fluid 1.008 to 1.010. So these two statistical findings which we have to write. Now let's begin with pregnancy. Pregnancy. In pregnancy, we have various terminologies in pregnancy. What are these terminologies? Whenever it comes to a pregnant lady, we start talking about that which lady is she? She is pregnant for first time. Then we will say she is primigravida. Gravida means number of pregnancy. And who is a primipara? Meaning of what parity is the number of deliveries after 20 weeks of pregnancy. That is parity. Gravida means even if abortion has occurred, she became pregnant, maybe she aborted before 20 weeks also. Then also a gravida number is given. But para number is given only to the lady who has delivered after 20 weeks of pregnancy. Then we say how much is the period of pregnancy, like period of amenorrhea. Suppose she says, Dr. Sahab, I had my periods on, say, for example, 10th of March. So period of amenorrhea will be calculated from 10th of March, means first day of last menstrual period. She is saying I had periods on 10th of March. So periods started on 10th of March, might have lasted for 4 days, 5 days. So period of amenorrhea is calculated from first day of last menstrual period. That is also called gestational age also. That is also called duration of pregnancy. Then there is another word called true conceptional age. True conceptional age or growth period means growth of fetus. True concept. What is the meaning of conception? Conception means fertilization. So true conceptional period is calculated from the day of fertilization. While gestational age or duration of pregnancy or period of amenorrhea is calculated from first day of last menstrual period. So these are various terminologies. Then we have trimester. Let's write down. Period of amenorrhea is also called gestational age. It is also called duration of pregnancy. So these are three terms. They are calculated from first day of last menstrual period. They are calculated from first day of LMP. What is full form of LMP? LMP means last menstrual period. LMP means last menstrual period. So these three terminologies, period of amenorrhea, which is also called gestational age, which is also called duration of pregnancy, it is calculated from first day of LMP. LMP means last menstrual period, first day of last menstrual period. And how much is it? It is 40 weeks or 280 days or 9 months plus 7 days. So normal period of amenorrhea or gestational age or duration of pregnancy is 40 weeks or 280 days or 9 months plus 7 days. There is another word as we discussed, growth period, which is also called true conceptional age. This is calculated obviously from what? What is the meaning of word conception? Fertilization. So obviously it is calculated from day of fertilization. Obviously, it is calculated from day of fertilization. From day of fertilization. These are three periods, growth periods. Correct it. This is not ovarian period. This is ovular period. Ovular. So, ovular period, embryonal period, fetal period. So we have three growth period. We have divided growth period or true conceptional age in three parts. Ovular period is up to 2 weeks from day of fertilization. Embryonal period is between 3 weeks to 8 weeks of pregnancy. This is the most vulnerable period of pregnancy, most dangerous period of pregnancy. We should give some extra care in this period. We should avoid any drugs because this is the period, embryonal period or 3 to 8 weeks period in pregnancy. This is the period of maximum teratogenicity, maximum risk of congenital malformations to fetus are between 3 to 8 weeks. Most vulnerable period of pregnancy, most dangerous period of pregnancy. Maximum abortions occur in this period. Maximum abortions occur up to 8 weeks of pregnancy. We will write in topic abortion also. And what is the fetal period? 9 weeks onward. So once it is 9 weeks and onwards, we start calling this fetus. Up to 8 weeks, this is called embryo, and 9 weeks onwards, this is called fetus. This is the right terminology. Between 3 to 8 weeks, term embryo is used. And embryonal period means 3 to 8 period is the most lethal, most vulnerable period of pregnancy. Then after these two terminologies, we have trimesters. We have various trimesters, but the latest development is now we have a fourth trimester also. We were having only 3 trimesters. First trimester is up to completion of 14 weeks. Datta's DC Datta textbook of obstetrics is still right, first trimester up to 12 weeks only. But Williams' 25th edition also said 14 and 26th edition also maintain first trimester is up to 14 weeks. Second trimester is after 14 weeks to 28 weeks, while the third trimester is from 29 weeks to 42 weeks. Now, the new addition is the fourth trimester. This fourth trimester is up to 12 weeks from date of delivery. It is up to 12 weeks from date of delivery. So this is a new addition in trimester. Now we don't have 3 trimester. Now we have 4 trimester. Fourth trimester is up to 12 weeks from date of delivery. What is the definition of postpartum hemorrhage? Definition of postpartum hemorrhage is that we will write in the topic postpartum hemorrhage. Definition is excessive bleeding out of vagina till 12 weeks after delivery. Means from date of delivery to 12 weeks. PPH is considered up to 12 weeks. This is the reason of introducing the fourth trimester so that we can call her for a postnatal visit also to take care of postpartum hemorrhage. This is up to 12 weeks. Let me show you these lines from latest edition of Williams, that is 26th edition. Williams 26th edition, which is the latest edition, what this 26th edition has to say. This is the book. From this book, I am quoting you the line. This is Williams textbooks of obstetrics, which is Guru Granth Sahib of obstetrics throughout the world. Harrison in medicine, Williams is having the same dignity as Harrison has in medicine. And this is the latest edition of Williams obstetrics, which is 26th edition. Let us see what this Williams 26th edition has to say. This Williams 26th edition has to say. This is Williams 26th edition. Topic is prenatal care and page number is 179. Topic is prenatal care, page number 179. This book has to say about the trimester. More recently, a fourth trimester has been recognized to emphasize the need for comprehensive postpartum care. The first trimester extends through completion of 14 weeks, the second through completion of 28 weeks, means the third is starting from 29 weeks through 42 weeks. The fourth is 12 weeks after delivery. So the fourth trimester is 12 weeks after delivery. So now we have fourth trimester. First trimester extends through completion of how many weeks? 14 weeks. The second through 28 weeks and the third through 42 weeks. The fourth is 12 weeks after delivery. 26th edition, topic name prenatal care, page number 179. Fine. So this is what Williams has to say regarding the trimester. What is the meaning of word gravida? Gravida means number of times of pregnancy. Gravida means number of times of pregnancy. How many times she became pregnant? This is gravida. Parity is number of delivery beyond the age of viability, and for definition of parity, 20 weeks is considered. Cutoff is 20 weeks. Number of delivery beyond age of viability. For parity, we consider 20 weeks. Number of deliveries after 20 weeks of pregnancy. Age of viability, there is no dispute about developed countries like America 20 weeks, developing countries like India 28 weeks. WHO had a debate between 22 and 24. 24. GTPAL scoring system, the most accepted scoring system to explain gravida and parity. This is GTPAL scoring system. How do we write this score? We write GTPAL like this. What is G? G is number of times of pregnancy, means G is gravida. T is number of term delivery. In GTPAL score, term is considered after 37 weeks. P is number of preterm delivery. A is number of abortion. L is number of living children. How many children she have right now? So this is GTPAL score, the most accepted scoring system to define gravida and parity. Suppose, say for example, she is pregnant for third time. She delivered twins 3 years before and she delivered twins 1 year before. So in first delivery, she delivered twins 3 years back. In second delivery, again she delivered twins 1 year back. And she is pregnant for third time. So she delivered 4 by now and she is pregnant for third time. So her gravida score is 3 or 5. Her gravida score is 3 because gravida is number of times of pregnancy. She is pregnant for third time. So number of fetuses have no role in defining gravida and parity. It is only number of times of pregnancy or number of times of delivery beyond 20 weeks which matters, not the number of baby. So very important point, number of fetuses are of no concern in gravida parity scoring. It is number of times of pregnancy. So our gravida score is 3 now, not the 5. It doesn't depend on number of number. L is number of living children in GTPL. Let's discuss few terminologies, single liner question. What is a nulli gravida? She never became pregnant. Very simple. Gravida means number of times of pregnancy. Nulli gravida, she never became pregnant. Primigravida, she is pregnant for first time. Very simple. Multigravida, when we use the word multi, when she is pregnant for at least two times, two or more than two times. What is a nullipara? Parity means number of deliveries after 20 weeks. Nulli means no, her pregnancy never attained age of viability, means for parity we consider it 20 weeks. Primipara, first time her pregnancy attained age of viability. First time her pregnancy attained age of viability. Multipara, multi means two or more than two times. Her pregnancy attained age of viability. Grand multipara, it's a PYQ. Our exam question, it was asked 3 years before in our exam, PYQ. Grand multipara. So, she has delivered four times delivered after 20 weeks. And she is now pregnant for which time? Now pregnant for fifth time. So, she has delivered four times after 20 weeks of pregnancy. And now she is pregnant for fifth time. Great grand multipara. Great grand. Great grand multipara, she has delivered nine times and now pregnant for 10th time. Our exam question was grand multipara. So grand multipara, she is pregnant for which time? Fifth time. But how many times she delivered after 20 weeks? Four times. Similarly, great grand multipara, how many times she delivered after 20 weeks? Nine times. But now she is pregnant for which time? 10th time. Who is a purpura lady? Purpura, the lady in purperium. And purperium is 6 weeks period after delivery. So a lady up to 6 weeks from date of delivery. A lady up to 6 weeks from date of delivery is called a purpura lady who is in purperium. And what is a purperium period? It is 6 weeks period after delivery. And postpartum hemorrhage is considered, we will discuss in that topic. Postpartum hemorrhage is considered till 12 weeks after delivery. So, we have designed the fourth trimester till 12 weeks after delivery. What is a parturient lady? Parturition means uterine contraction. Parturition means uterine contraction. So, if she is in labor, a lady in labor is called a parturient lady. Parturient means uterine contractions. Meaning of word parturition, you can write down meaning of word parturition is uterine contraction. So a lady in labor is called parturient lady. There is a word called pseudocyesis. Pseudocyesis. Pseudo means false. Pseudo means false. Cysis means pregnancy. So this is false pregnancy. False pregnancy is pseudocyesis. What is this false pregnancy? She thinks that she is pregnant, but actually not pregnant. She comes to you, Doctor Sahab, I am pregnant. She is having a pendulous belly, a massive abdomen. Doctor Sahab, I am pregnant. You say, okay, you are pregnant. Then we will try to palpate fetal part. Nothing is palpable. When we will try to auscultate fetal heart sound, nothing is audible. Then we will do ultrasound. Ultrasound, there is no fetus inside. We will say that you are not pregnant. Then she will start fighting. I didn't have menses. Maybe she is having secondary amenorrhea due to some other reason. And she is gaining weight, whatever the reason is, she thinks that she is pregnant, but she is not. So, how can you say that you are not pregnant? These are called absolute signs of pregnancy are absent. We'll write just after 5 minutes. What are the absolute signs of pregnancy? How can you say that you are not pregnant? We will say there is no fetus inside. I cannot hear any fetal heart sound. I cannot palpate any fetal part. And when ultrasound was not available, then we were doing X-ray. And in X-ray, we were seeing fetal skeleton, bones of fetus in X-ray. That could be seen after 16 weeks of pregnancy. So these four are absolute signs of pregnancy. They will be absent, and this is how we will try to convince her that you are not pregnant. We can't see any of these four. So absolute signs of pregnancy are absent in pseudocysis. We'll just write after 5 minutes. Fine. Now, few terminologies. Early term that I told you, we will write everything, don't worry. 37 weeks to 38 weeks, 6 days. This is early term. Overlap with pediatrics also. What is a term? Term is 39 weeks to 40 weeks, 6 days. This is term. What is a late term? Late term is 41 week to 41 week, 6 days. What is a post term then? Post term is 42 or more than 42 weeks. What is a preterm then? Preterm is before 37 weeks. So before 37 it is preterm, 42 weeks onwards, including 42. Either 42 or more than 42. This is post term, while early term starts at 37 weeks. Calculation of expected date of delivery. How to calculate EDD? It is done by which formula? Niggles formula. Simple question. So EDD is calculated, expected date of delivery is calculated by which formula? Niggles formula. What is this Niggles formula? Niggles formula, a very popular way in the ward says, whatever she is saying, Dr. Sahab, I had said on this date, suppose 10th of March, we will just add 9 months and add 7 days. 9 months plus 7 days. But believe me, that is not Niggles formula. 9 months plus 7 days is not Niggles formula. We have already written 9 months plus 7 days in period of amenorrhea. 40 weeks or 280 days or 9 months plus 7 days. That is period of amenorrhea. But that is not Niggles formula. According to Williams, what is Niggles formula? Add 7 to days and subtract 3 months. This is Niggles formula. And this Niggles formula is applicable for 28-day cycle. For example, let's understand with example. If she says, Dr. Saab, I had last menses on 10th of April, first day of last menstrual period. That's the LMP means first day of last period. I had periods on 10th of April. When will I deliver? She is asking you. She has come to you. She is saying that I had periods on 10th April. So when should I deliver ideally? Oh, you will apply. You are a big doctor. You know Niggles formula. So you will add 7 to the day. 7. So 10 plus 7 is 70. EDD would be 17th. How many days are added? 7. And how many months are subtracted? 3. So 4 minus 3 is 1. So her expected date of delivery is 17 January 22. This is her expected date of delivery. But this Niggles formula, adding 7 to days and subtracting 3 months, it is applicable for 28-day cycle. We'll just discuss after 2 minutes. What is another variant of the formula? But if month is changed while adding days. What does it mean? Another example. Suppose her LMP is 28th April. She says, Dr. Saab, I had periods on 28th of April, 21. Now what has to be done? How many days are added? 7. So if you start counting after 28, 29, 30, 1, 2, 3, 4, 5. So it becomes 5 after addition of 7 days. But what has happened? How we got 5? Once we started counting after 28, we got 5 from April after 29, 30, then 1st. The month is changed. But if months is changed while adding days, write down subtract 2 months. Subtract 2 months. But if month is changed while adding days, subtract. This is Nicholas formula. So now 28 plus 7 is 5. Because the month is changed, now we will subtract 2. So EDD has become 5th of February 2022. If month is changed while adding day. Okay. We know this Nicholas formula is applicable for regular 28-day cycle. But if it is a prolonged cycle, we have to add additional days in EDD. For example, in this example only, the first example, she says, Dr. Saab, I had periods on 10th of April. She had periods on 10th of April 21. And she says, Dr. Saab, I get periods after every 30 days. She is not getting periods after every 28 days. She gets menses after every 30 days. Now, Nicholas formula is applicable for 28-day cycle and she gets period after every 30 days. Means it is a prolonged cycle, normal cycle or a short cycle. It is a prolonged cycle. Prolonged by how many days? 2 days. Prolonged by 2 days. So now EDD would be 17th of January or 19th of January. 19th of January. Because now you have to add 2 days to 17. So 17 plus 2, 19. Let's take another example. We are talking about this LMP only. This LMP is 10th of April. And she says, Dr. Saab, I get periods after every 40 days. Suppose her cycle length is 40 days. This Nicholas formula, addition of 7 days, subtracting 3 months, is applicable for 28-day cycle. And if she says, Dr. Saab, I get periods after every 40 days, her cycle length is 40. It is a prolonged cycle. How much it is prolonged? This formula is applicable for 28-day cycle and now she is having 40-day cycle. So how many days are additional? 12 days are prolonged. Now what is the formula? If it is a prolonged cycle, add additional days in EDD. Now 12 days are additional. So what should be the EDD now? 17 plus 2, 20, 17 plus 10, 27 plus 2, 29. So her EDD would become 29 January 2022. Because she is having prolonged cycle by 12 days, we will add 12 days to the EDD. Clear to everyone? Fine. Now another way, but if cycle is shorter. And if cycle is shorter, subtract shorter days. Let's again understand this with the example. If cycle is shorter, we will subtract shorter days. Now, in the same example, if she comes to us and say, Doctor, I had periods on 10th of April. Same example. She had periods on 10th of April. But she says, Doctor, I get periods after every 25 days, not after 28 days. If she gets periods after every 25 days, so she is having a short cycle or a normal cycle or prolonged cycle, short cycle. How many days are short here? 3 days are short here. So what the formula says, if cycle is shorter, subtract shorter days. So now her EDD would be 17th of January or 14th of January. 14th of January. Because cycle is short by 3 days, so we will subtract these 3 days. 17 minus 3 would become 14. Symptoms. What are the symptoms? First trimester symptoms. Earliest symptom of pregnancy or first symptom of pregnancy is amenorrhea. Why she missed her periods in pregnancy, we have discussed it multiple times. Because syncytial trophoblast secrete HCG which support corpus luteum. What are other symptoms? Morning sickness. What is this morning sickness? Morning sickness means nausea and vomiting. She is suffering from nausea and vomiting in pregnancy. What is the cause of nausea vomiting? HCG. This is mainly due to, although other hormones are also responsible, growth hormone, prolactin, many hormones are increased in pregnancy. They may be responsible for nausea vomiting, but mainly it is due to HCG, human chorionic gonadotrophin. Why maximum nausea and vomiting in morning? Why it is called morning sickness? Why not evening sickness? Because HCG is maximally concentrated in blood in morning, because she less often goes for micturition during night. Because HCG is maximally concentrated in morning, the best urine sample to diagnose her pregnancy is the early morning sample. Another very important question for our exam that we will discuss after 15 minutes. So, what is the best time to collect the urine from her to diagnose whether she is pregnant or not for a urine pregnancy test? Early morning sample. Because HCG is in maximum concentration during morning. This is why she feels maximum nausea vomiting during morning. Increase in frequency of micturition. What is the reason? Why she is going for micturition quite often? Because when this uterus, when this fetus start growing, when this fetus start growing inside uterus, there occur uterine enlargement. And this enlarging uterus start irritating urinary bladder. You remember symptom of anterior wall cervical fibroid was increase in frequency of micturition. Similarly here, this enlarging uterus is irritating urinary bladder. So she start complaining of increase in frequency of micturition. Why she is feeling tired? Why she is feeling fatigued, exhausted, lethargic? Because now she is living for two living creatures and she may be eating for one only. She may not be aware that she has become pregnant. She has not yet increased her routine calorie requirement. She is eating for one and she is living for two. She feels exhausted, feels tired. Another first trimester symptom is breast discomfort. Another first trimester symptom is breast discomfort. Why she is feeling breast discomfort? Because in this bitia, breasts are now being prepared for lactation. They are getting enlarged. Breast discomfort is due to enlargement of breast. Why breasts are enlarged in pregnancy? Because now they are being prepared for lactation, breastfeeding. This is the reason for breast enlargement. Milk synthesis has to happen. These are first trimester symptoms. Out of these, the earliest symptom, the first thing she comes to you and say, Doctor Saab, I did not have menses this time. I did not have periods this time. This is amenorrhea. Second trimester symptom. Second trimester symptom, she start that fetus is moving inside. So she start recognizing that there is some life inside. Some life inside, कोई जिंदगी है अंदर. इसी को कहते हैं quickening. This is called quickening. What is this quickening? Perception of fetal movements. Perception of fetal movements. She start recognizing fetal movement. She start recognizing there's some life inside which is moving inside. This is called quickening. Second trimester symptom. Who will experience quickening earlier? A multipara or a primipara? Multipara, of course, because she is more experienced. She experienced these movements in previous pregnancy also. So multipara experience quickening 16 weeks onward, while a primipara can experience quickening only 18 weeks onwards. Important single liner questions. Quickening is experienced by a primipara how many weeks onwards? 18 weeks onward. while multi experience it 16 weeks onward. Very simple. Perception of life. Third trimester symptom. Third trimester symptom is lightening. Lightening. She start feeling lighter because after 36 weeks of pregnancy, fetus has started descending. Fetus start descending. So diaphragm come down because now this fetus start descending after 36 weeks of pregnancy. Because fetus is coming down, so obviously diaphragm is also going down. So her respiratory discomfort is relieved. And reappearance of increased frequency of micturition. Why there is reappearance of increased frequency of micturition? So increased frequency of micturition is seen in first trimester. When this fetus started growing, it was a small fetus. It started growing, was coming out of pelvis into abdomen, so it has started irritating urinary bladder. In second trimester, fetus went up. So there was no increased frequency of micturition in second trimester. What's happening in third trimester? This fetus has again started descending. Because this fetus has started descending, again it has started irritating urinary bladder. So increased frequency of micturition is seen in first trimester and third trimester, but not in second trimester. Fine. Signs of pregnancy, first trimester signs. Remove this 6 weeks from here. We will write it just after 1 minute. Earliest sign in pregnancy is Goodell sign. Earliest sign in pregnancy is Goodell sign. What is this Goodell sign? Goodell sign means softening of cervix. Goodell sign means softening of cervix. Cervix becomes soft. And this happens due to venous congestion. And it is experienced at 6 weeks of pregnancy. This is the earliest sign of pregnancy. Experienced at 6 weeks, and this softening of cervix occurred due to venous congestion. What does it mean? What is this venous congestion? Why does it happen? What is happening in pregnancy? Blood flow in uterine artery increase. And by 22 weeks of pregnancy, it is increased by 10 times. 10 times increase by 22 weeks. So it has started increasing in early pregnancy. What is the reason? Why this blood supply in uterine arteries is increasing? The descending cervical artery is a branch of uterine artery. So more blood flow in descending cervical artery also, which is a branch of uterine. Why blood flow is increasing in uterine artery? To supply more blood to uterus. And where will it go from uterus? Uteroplacental circulation, fetoplacental circulation. Finally, who will receive this increased blood? Fetus. So blood flow is increasing in uterine artery to meet out the demands of growing fetus. And what will happen if blood flow is increasing in cervix? If we will do a PV examination, first of all, we will palpate cervix only. This is why we are talking about cervix in the sign. More blood flow to cervix, blood is liquid or solid? Blood is liquid. So if more liquid is going to cervix, what will happen to cervix? It will become soft. More blood is going to cervix, more veins are dilated in cervix. So it will become soft because of more liquid. So softening of cervix is due to venous congestion. And because of this increased supply of blood to cervix, there occur a color change also. Cervix and vagina, they become bluish violet in color because of venous congestion. Color change starts at 8 weeks of pregnancy. Changes in consistency are appreciated as early as by 6 weeks of pregnancy. Cause of color change, bluish violet cervix vagina, which is a Jacomer or Chadwick sign, And cause of Goodell sign is same, venous congestion. But change in consistency is appreciated 2 weeks earlier, that is as early as 6 weeks, while color change is appreciated by 8 weeks. Let's write down. Fine. Other signs, all other signs in first trimester, they are appreciated at 8 weeks. Only Goodell sign is appreciated at 6 weeks. All other signs in first trimester, they are appreciated at 6 weeks. So first sign was the Goodell sign. Another sign is Jacquemer or Chadwick sign. What is this Jacquemer or Chadwick sign? Bluish violet discoloration of cervix and vagina, again due to venous congestion. I told you, color change is appreciated at 8 weeks. All these signs at 8 weeks, except Goodell at 6 weeks. Another sign is a Osiander sign. What is this Osiander sign? Osiander sign, suppose you are doing upper vaginal exam. This is uterus and this is cervix. If you are doing a per vaginal exam, this is uterus, this is cervix. You are doing per vaginal exam. And if you turn your fingers towards right adnexa or left adnexa means tubo-ovarian region. Right tubo-ovarian region, left tubo. When you are doing PV and if you turn your fingers towards right or left side, your fingers will be able to palpate pulsations of uterine vessels. Why your fingers are able to palpate pulsations of uterine vessels? Because of increased blood supply in uterine vessels to meet out the demand of growing fetus. This is called Osiander sign. Let me explain you few other signs, then we will write together. There is a Pisca sex sign. What is a Pisca sex sign? When there is uterine enlargement in pregnancy, it is not central enlargement. It is not a central enlargement like this. There is more enlargement of uterus towards right side. Why more enlargement of uterus towards right side in pregnancy, not in the center? This is called asymmetric enlargement of uterus. Because normal position of uterus is slightly dextro-rotated. It is slightly rotated towards right side. This is why more enlargement towards right side. Then more enlargement towards anterior side or posterior side. More enlargement towards posterior side. Because most common site of interstitial implantation was upper posterior. So most common location of placenta was also upper posterior. So during pregnancy, more enlargement of uterus towards right and posterior side, which makes it an asymmetric enlargement of uterus, which is the Pisca sex sign. What is the Palmer sign? If you put your palm, suppose this is mother, this is not fetus right now. If you put your palm on her abdomen, your palm sense some tone. Your palm sense some tone here. Why your palm sense some tone here? Because of uterine contractions. Uterine contractions are present throughout pregnancy. Braxton-Hicks contraction. But these contractions are not palpable. They are neither palpable nor they produce any pain. Because throughout pregnancy, they remain less than 8 millimeter of mercury intensity. Uterine contractions are normally palpable when they are at least of 10 millimeter of mercury intensity. And they start producing pain when they are of at least 15 millimeter of mercury intensity. Throughout pregnancy, because they remain less than 8 millimeter of mercury intensity, they are neither palpable nor they produce pain. Braxton-Hicks contraction, it is just your palm is sensing some tone only, that's all. No palpation of contraction. What is the Hagar sign? Hagar sign is a bimanual sign. Suppose this is uterus. You put your fingers in her vagina like this. And you put your other hand. Suppose this is pregnant lady. You put your fingers in her vagina like this and you put your other hand in her suprapubic region. So your vaginal fingers and abdominal fingers, they seem to touch each other. They seem to approximate each other. They cannot touch each other. You have put one finger in her vagina and your hand is in suprapubic region. One is inside, other is outside. But because cervix has become very soft in pregnancy, your vaginal and abdominal fingers seem to approximate each other. This is the bimanual sign. This is Hagar sign. Let's write. Osiander sign is pulsation of uterine vessels on PV exam, on per vaginal examination. Piscasex sign is asymmetric enlargement of uterus. So enlargement of uterus in pregnancy is asymmetric. It's not symmetric. More towards right and posterior side. More on right and posterior. Piscasex sign. Palmer sign, as we discussed, if we put our palm on her abdomen, our palm sends some tone. And this is due to uterine contraction of less than 8 millimeter of mercury intensity. So throughout pregnancy, uterine contractions remain less than 8 millimeter of mercury intensity. This is why they are neither palpable nor they produce pain. Uterine contractions are normally palpable when they are of at least 10 millimeter of mercury intensity. And uterine contractions start producing pain. ये दर्द का एहसास देना शुरू करते हैं when they are of at least 15 millimeter of mercury intensity. Because throughout pregnancy, they remain less than 8 millimeter of mercury intensity. They are neither palpable nor they produce pain. These are called Braxton Hicks contractions. Another sign in first trimester of pregnancy is Hagar sign. This Hagar sign is a bimanual sign. It can be appreciated between 6 to 10, but best answer is 8. Average of 6 to 10 is 8. This is a bimanual sign. Only bimanual sign in pregnancy is Hagar sign. Bimanual sign. And in this sign, abdominal and vaginal fingers seem to touch each other. They cannot touch. One is inside, one is outside. So, which one is the only bimanual sign in pregnancy? Hagar sign. Which is the earliest sign of pregnancy? Goodell sign. Which is the earliest symptom in pregnancy? Amenorrhea. Only Goodell sign is appreciated at 6 weeks. All other signs of first trimester, they are appreciated at 8 weeks of pregnancy. Let's have a look at these images. These are on next page, page number 168 in our workbook. What is this sign? This is cervix and vagina. If you are doing a per speculum examination, you can see bluish violet cervix vagina. So this is a Jacquemer or Chadwick sign. We will label this sign. What is this sign? This is bimanual sign. You can see our fingers are inside vagina and our other hand is on suprapubic region. So in bimanual exam, abdominal and vaginal fingers, they seem to touch each other because cervix has become markedly soft in pregnancy because of venous congestion. If cervix is soft, that is called Kuder sign. Color change is called Jacquemer or Chadwick sign. Let's label the image. This is the image of Hagar sign. This is the image of Jacquemer or Chadwick sign. Image of Jacquemer or Chadwick sign. Second trimester signs. There are two signs in second trimester. We can try to palpate her fetal parts. Palpation of fetal parts and auscultation of fetal heart sound with stethoscope. These are clinical signs. Clinical means inspection, palpation, percussion, auscultation. So auscultation only by stethoscope is permitted in clinical exam. These palpation of fetal parts and auscultation of fetal heart sound by stethoscope, this is possible 18 weeks onward. It will be same in primary and multi because we are doing. She is not telling. Sign means we are eliciting sign. Symptom is told by patient. Sign is elicited by doctor. Third trimester sign is lightening and reappearance of increased frequency of micturition. So third trimester symptoms and sign are same. Third trimester symptom and sign are same. Lightning is also called a welcome sign. Why lightning is also called a welcome sign? We are ready to welcome the newborn now. As soon as she says, "Doc's up," I am relieved. I'm feeling less respiratory discomfort now. Nothing is going to happen soon. I'm fine now. The moment she says she is relieved, her respiratory distress is reduced now, we immediately realize everything is going to happen now. Because the boarding pass of fetus is ready, fetus has started descending. Investigations. Investigation in pregnancy. First MCQ. What is the earliest investigation in pregnancy? Or the first investigation in pregnancy is urine pregnancy test. This is urine pregnancy test. This urine pregnancy test is popularly known as UPT. So first investigation to diagnose pregnancy is urine pregnancy test. And what is the best sample, best urine sample to diagnose pregnancy? This is early morning sample. But the problem with urine test is it is positive only when she is at least 1 day overdue. Only when she is at least 1 day overdue. What does it mean? What is the meaning of overdue? Suppose she has to have her periods. Today is fine. 16th of, let me tell you. Today is 16th of October. 16th. Suppose she gets period on 15th of every month. 15th. She did not have periods yesterday. So today she will come to you and say, "Doc Saab, I was about to get the periods yesterday. That is on 15th because I get periods on 15th of every month. I have a 30-day cycle. And I didn't have period yesterday and today I didn't get. So today on 16th, she will be considered overdue by 1 day. Tomorrow she will be considered overdue by 2 days. Clear? This is the meaning of word overdue. We know HCG secretion starts 7 days after fertilization. And then it is doubling after every 48 hours. So after doubling every 48 hours, minimum concentration of HCG, which is required for a urine pregnancy test to be positive, is attained only when she misses her periods by 1 day. So by urine pregnancy test, you can diagnose pregnancy only after she missed her period. Urine pregnancy test is based on antigen-antibody reaction. HCG in the urine acts as an antigen, and that urine pregnancy test kit contains an antibody. HCG is acting as antigen. Okay, you cannot tell her. Fertilization happened before this. Suppose this is a 28-day cycle. If she is having a 28-day cycle, in this 28-day cycle, fertilization is supposed to occur on which day? 14th day. And in 28-day cycle, HCG secretion should start on which day? We know HCG secretion starts on 7 days after fertilization. It starts on 7 days after fertilization. 28-day cycle, fertilization occurred on 14th day. So SCG secretion should start on 14 plus 7, that is 21st day of cycle. So it started on 21st day. But you can diagnose pregnancy only on 29th day when she is overdue by at least 1 day. If she comes to you and say, Doctor, I have a function at my home, or I have to travel abroad, or there is any valid reason. She wants to know whether she is pregnant much before. She came to you, suppose this is 16th today. She came to you, suppose somewhere around 5th, 4th or 5th of October. And she is saying, Doctor, I had intercourse around the day of ovulation, and I am suspicious, I am doubtful that I became pregnant. Oh, I have to go to California. I have a flight on 14th of October. I have to fly on 14th of October. Can you tell me whether I am pregnant or not? If you are waiting for a urine pregnancy test, you can tell her that she is pregnant only on 16th October, not before that. And she came to you on 5th of October. She has to fly to California on 14th of October. And she wants to know so that she can cancel her trip. You can tell her that you are pregnant by a blood test now, not by a urine test. What will you do in this blood test? Again, we will pick up SCG in this blood test. In urine also, we were picking up SCG. In blood, we will pick up SCG. Sensitivity of our blood test is very high. They can pick up SCG in blood right on the day on which its secretion begins. So, secretion of SCG begins 7 days after fertilization. Means if it is a 28-day cycle, fertilization occurred on day 14, secretion of SCG will start on day 21. So, how many days before overdue you can tell her that you are pregnant? 7 days before overdue. So 1 week before overdue, you can tell her you are pregnant with a blood test. Blood tests are fluoroimmunoassay, radioimmunoassay. Fluoroimmunoassay can pick up as little as 0.001 milli-international units per ml SCG, while radioimmunoassay can pick up as little as 0.002 milli-international units per ml SCG. So these two blood tests are very good blood tests. That's right. Fine. But to know before overdue, she wants to know before overdue, or the best test is not urine test. Urine test is answer to the question earliest test or first test, and diagnosis can be done 7 days before overdue. 7 days before. These are various blood tests to diagnose pregnancy. Fluoroimmunoassay can pick up as little as 0.001, while radioimmunoassay can pick up as little as 0.002. The most sensitive is FIA. Fluoroimmunoassay is popularly known as FIA, while radioimmunoassay is popularly known as RIA. So which one is better? Is more sensitive? FIA, fluoroimmunoassay. So in pathology, we have two tests, urine test and blood test. Let's move to radiology. Which radiological modality is safe in pregnancy? Ultrasound. Ultrasound is safe in pregnancy, safest. It is the safest modality because ultrasound does not have rays, it has sound waves. Let's draw a ray diagram. Let's draw a ray diagram. First structure visualized in pregnancy by ultrasound is gestational sac. This is the first structure visualized, gestational sac. First structure visualized in pregnancy by ultrasound is gestational sac. Second structure visualized in pregnancy by ultrasound is yolk sac. Third structure visualized in pregnancy by ultrasound is embryo. The moment you see embryo in ultrasound, at the same moment, you should be able to see cardiac pulsations also, heartbeat also. The moment you see an embryo, it should be seen pulsating. The saying is embryo and cardiac activity, they are visualized by ultrasound at the same time. Gestational sac is visualized by ultrasound by 4 weeks, 3 days. Yolk sac is visualized by ultrasound by 5 weeks. We are talking about transvaginal sonography. While cardiac activity or embryo, they are seen between 5 to 6 weeks. This is TVS, transvaginal sonography. TVS. Which ultrasound gives information earlier? Which ultrasound is better? Transvaginal sonography is better because it gives information earlier. Why? How do we do transvaginal ultrasound? We put the probe, ultrasound probe in vagina. So probe is here, it's like this. The probe is here. Transvaginal probe is here. So it's near gestational sac. While abdominal ultrasound is over abdomen. It gives information approximately 1 week later to transvaginal sonography. So by TVS, we see, for example, 456, by TS 567. Easy way to remember, by TVS 456, by TS 567. So your MCQs here would be, first structure visualized in pregnancy by ultrasound is gestational sac. MCQ number 2. Gestational sac can be visualized earliest by ultrasound by what time? 4 weeks, 3 days. If examiner does not write by transvaginal sonography or by transabdominal sonography, we will assume it by transvaginal sonography. Means gestational sac can be visualized as early as by 3 days. Of course by TVS. 1 week approximately later by TAS. Cardiac activity can be visualized earliest by ultrasound by what time? 5 weeks. What are absolute signs of pregnancy? Absolute signs are also called positive signs of pregnancy. Absolute signs or positive signs of pregnancy. What are these? Absolute signs or positive signs of pregnancy are auscultation of fetal heart sound. We can hear fetal heart sound. Palpation of fetal parts. If you are doing an ultrasound, you can see fetus, you can see fetal cardiac activity. Of course, we don't do X-ray now. We were doing it in old time. And in X-ray, fetal skeleton could be seen. At that time, this MCQ was very popular. Fetal skeleton can be seen after how many weeks of pregnancy? After 16 weeks of pregnancy. These are 4 absolute signs of pregnancy. These are absent in pseudocyesis. Let's write down these absolute signs are absent in pseudocyesis. What is pseudocyesis? She says that she is pregnant, but you are saying no, you are not pregnant by these 4 things that these are not same. Important MCQ, what is the best clinical sign of pregnancy? Best clinical sign. If the word clinical is written in MCQ, you cannot use ultrasound machine because clinical means inspection, palpation, percussion, auscultation. You can see the patient, you can palpate the patient, you can percuss the patient, you can hear heart sound. So best clinical sign is auscultation of fetal heart sound. This FHS means fetal heart sound. Auscultation of fetal heart sound by stethoscope. By stethoscope. Clinical means stethoscope. We can hear fetal heart sound by fetal Doppler also. I will show you. If this question number 2, best sign of pregnancy. The word clinical is removed. You can utilize any satellite from NASA to diagnose pregnancy. Now the whole world is open for you. You can use any machine available in the world, but we use only ultrasound because this is safest in pregnancy. Visualization of fetal heartbeat. Visualization of fetal heartbeat means fetal cardiac activity by ultrasonography. Visualization of fetal cardiac activity by ultrasound. So if the word clinical is removed, we can use any machine, but we use only ultrasonography. If the word clinical is mentioned, only stethoscope. This is the image given in our workbook. This is how these gestational sac, yolk sac, and embryo are seen in early pregnancy. This is the gestational sac. This is the first structure visualized in pregnancy by ultrasound. What is the second structure visualized in pregnancy by ultrasound? This is yolk sac. The first one was gestational sac, GS, gestational sac. Second is yolk sac. The third structure visualized in pregnancy by ultrasound is this embryo, fetal pole or embryonal pole. And the saying is the moment you visualize fetal, you should be able to visualize cardiac activity also. This is beating. This fetus is not silent. This is beating. This is the early intrauterine pregnancy. Let me show you the fetal Doppler also when we are examining fetal heart sound. Let me show you the fetal Doppler. This is fetal Doppler. And this is how we count fetal heart rate with fetal Doppler. This is the device fetal Doppler like this. This is not a stethoscope. So by this fetal Doppler, we can count, we can listen fetal heart sound 10 weeks onward. But this is not clinical sign. Clinical only by stethoscope. By stethoscope, we can hear fetal heart sound 18 weeks onward. By this machine, fetal Doppler, we can hear fetal heart sound 10 weeks onward. And by ultrasound, we can see fetal cardiac activity by 5 weeks of pregnancy by TVS. So let me just write down here where we wrote this by stethoscope. Here only you can write by fetal Doppler, by fetal Doppler. You can hear fetal heartbeat 10 weeks onward. Here only you can write down by ultrasonography, we can see fetal heartbeat 5 weeks onward. But clinical sign is 18 weeks onward. By stethoscope, you can hear fetal heart sound 18 weeks onward. By that machine, fetal Doppler 10 weeks onward. By ultrasound, 5 weeks onward. We have just written 5, 6, 7. 5, 4, 5, 6, 5, 6, 7. This was fetal Doppler. Let me show you one more thing, just one. This is by stethoscope. This is how we hear fetal heart sound by stethoscope. This is clinical sign. The best clinical sign of pregnancy is auscultation of fetal heart sound by stethoscope. 18 weeks onward. This is 18 weeks onward. While with fetal Doppler, we can hear fetal heart sound how many weeks onward? 10 weeks onward. And by ultrasound, 5 weeks onward. Let me show you how do we measure fetal heart sound. Just when we are doing an ultrasound and we have to count the fetal heart rate. Look, this is how we do an ultrasound. This is ultrasound beam. This is passing through this fetal heart. This is fetal heart. And when this ultrasound wave passes through fetal heart, this fetal heartbeat is shown in the form of this waveform on ultrasound monitor. This is called BM mode ultrasound. BM mode. This is B mode and this is M mode. So this is a combination of BM mode. So fetal heart rate tracing, advanced radiology. So this is seen on BM mode ultrasound. So we can see that heart is beating. This is a live fetal. And if by chance abortion has occurred, I will show you another image in the topic of abortion. You will not see this cardiac tracing. The first structure visualized in pregnancy by ultrasound is gestational sac. In this image, only gestational sac is seen, as you can see. Only gestational sac. Yolk sac and embryo have not yet appeared. Second to appear is yolk sac, and third in the sequence is embryo. Let's solve the question. If LMP is 15th May 2021, 15th May 2021. In 29-day cycle, EDD would be, if LMP is 15th May 2021, in 29-day cycle, EDD would be. How to solve these questions? First of all, you calculate EDD in a 28-day cycle. Just act like a child. Just act like a fifth class student. I am acting like a fifth class student. I will calculate EDD considering 28-day cycle first. 15 plus 7, 22. Okay. 5 minus 3, 2. Nigle's formula is add 7 days and count back 3 months. So 15 plus 7, 22. 5 minus 3, 2. So EDD is 22nd February 22. Okay. Now I will read the question again. How many day cycle? 29 days. This formula was applicable for how many day cycle? 28. Now cycle is prolonged by 1 day. So how much would I add? 1. So now answer would be 23 February. So 22 February is not the answer. 21 is not the answer. 23 is answer. 24 is not the answer. This is the best way. Suppose if this 29-day cycle is not written in the question, then answer would be 22nd February. Suppose instead of 29, it is written 27-day cycle, means short cycle, 1 day short cycle. If it is 1 day short cycle, then 22 minus 1, then answer would be 21 February. Suppose this is not a 29-day cycle, examiner write this is a 30-day cycle. If this is a 30-day cycle, we will add 2. So 22 plus 2, then answer will become 24th February. So we have to read the question very carefully. In this question, because it is 29-day cycle, cycle is prolonged by 1 day, so 1 day would be added to 22. First of all, we calculated EDD as if we calculate in a 28-day cycle by adding 7 days. Next question. A 30-year-old lady. Her age is 30 years. She is a 30-year-old lady. She delivered twins 6 years back. Okay. And single baby 2 years back. Okay. She presents with 12 weeks pregnancy now and has 2 alive children. Okay. Her GTPL score is, okay, behave like a 5th class child. I behave like that. GTPL, because my maths is weak. So I behave like that. G is gravida, number of times of pregnancy. Delivered twin 6 years back, single 2 years back, presents with 12 weeks pregnancy. So she is pregnant for which time now? Third time. Okay. T is number of term pregnancy. Delivered twin 6 years back and single baby 2 years back. So how many term deliveries? 2. She presents with 12 weeks now. How many preterm deliveries? Nowhere it is written that she delivered preterm. A is number of abortion. How many times she had aborted? Nowhere it is written that she has aborted. How many living children she has? 2. Now we have to match it. 32002. 4. Nowhere. It has to be 3. Second one G3, third one G3, fourth one G3. So all 3 looks correct. T is 2. T is 2, T is 2, T is 2. In remaining 3, T is 2. Tough fight. P is 0. Nowhere it is written that she had preterm. P0, this is gone. P0, P1, P1. Now P0 is here in these two. A0, 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 A1. Oh my God. So it looks better. L2, here L2, here L3. So what is the answer? This is how we calculate GTPL score behaving like a small child. Best test to diagnose pregnancy before being overdue is? Best test to diagnose pregnancy before being overdue? UPT. It cannot be urine pregnancy test. Yes, it is blood test. But read all the four options. RIA and FIA. RIA and FIA. FIA. Now, examiner has given a better answer than blood test. There are two types of blood tests, RIA and FIA. RIA is radioimmunoassay, FIA is fluoroimmunoassay. Which one is best? Fluoroimmunoassay. So what is the best answer here? Fluoroimmunoassay. If period of amenorrhea is 11 weeks, fetal growth period in weeks. So examiner has given this question that period of amenorrhea is 11. Fetal growth period in weeks. Period of amenorrhea is calculated from first day of last menstrual period, while fetal growth period is calculated from day of fertilization. Now you tell me. Suppose she had periods on 1st of March. So period of amenorrhea will be calculated from 1st of March. But did fertilization occur on 1st of March? No. Fertilization didn't occur on 1st of March. She says, Dr. Saab, I had last periods on 1st of March. 1st of March is first day of last menstrual period. But if it is a regular 28-day cycle, fertilization occurred on which day? 14th of March. So growth started from 14th March. True conceptional period or growth period is calculated from day of fertilization. So growth period or true conceptional period is obviously how many weeks less than period of amenorrhea? It has to be 2 weeks less because fertilization starts after 2 weeks if it is a regular 28-day cycle. So growth period or true conceptional period is 2 weeks less while period of amenorrhea is 2 weeks more. Let's solve the question. If period of amenorrhea is 11 weeks, fetal growth period is 9. Now, I am asking you another question. If growth period is 10 weeks, if growth period or true conceptional period is 10 weeks, how much is the period of amenorrhea? 12 weeks. Period of amenorrhea 2 weeks more. Okay, another example. If period of amenorrhea is 9 weeks, how much is the true conceptional period? 7 weeks. Because true conceptional period will be 2 weeks less than period of amenorrhea. घबराना नहीं है, डरना नहीं है. Don't be afraid of. Don't be afraid. एक बहुत अच्छी बात बोलता हूं. नाकामयाब लोग जो होते हैं ना इस दुनिया में, जो नाकामयाब होते हैं, नाकामयाब लोग दुनिया के फैसले से, दुनिया के भय से, दुनिया के डर से अपने फैसले बदल देते हैं. चल रहे थे किसी रास्ते पे, चलने लगते हैं किसी रास्ते पे. और जो कामयाब लोग होते हैं ना, वो अपने फैसले से दुनिया बदल देते हैं. हमें कामयाब लोगों की श्रेणी में आना है, अपने फैसले से दुनिया बदलनी है. हमारा फैसला पता है क्या है? हमारा फैसला है हमने रिवीजन करके ही सोना, हमने रिवीजन पूरी कंसंट्रेशन के साथ करना. यह हमारा फैसला है. हम अपने फैसले पर अडिग रहेंगे और अगर हम अपने फैसले पर डटे रहे ना, हम दुनिया बदल देंगे, लोगों के मुंह बदल देंगे, लोगों के मुंह बंद कर देंगे. जस्ट हैव कॉन्फिडेंस इन यू. थोड़ा सा और पढ़ते हैं. फाइन. चेंजेस इन प्रेगनेंसी. बस थोड़ा सा 15 मिनट और पढ़ेंगे. 15 मिनट्स. चेंजेस इन प्रेगनेंसी. What are the changes on face? What changes occur on face? Look here. This is the change on face. This is how it looks like. This is the change on face. What is this change on face? There occur brownish black pigmentation, particularly on cheeks and nose. Brownish black pigmentation particularly on cheeks, nose, and forehead. Cheeks, nose, and forehead. What is the reason? What is the cause of this brownish black pigmentation in her? Cause of this brownish black pigmentation in her is increase in melanin. Why melanin has increased in her? Because of increased melanocyte stimulating hormone. Why melanocyte stimulating hormone has increased in her? Because of hyperplasia of pituitary gland. Why there is hyperplasia of endocrine glands in pregnancy? Because fetus wants hormone, fetus wants a growth. So there occur hyperplasia of endocrine glands in mother. And because of hyperplasia of endocrine gland in mother, various hormones are increased, melanin is increased, and this melanin is responsible for this pigmentation, which is called pregnancy mask or chloisma or melasma, chloisma gravidarum or melasma or pregnancy mask. So this is the change in phase. The change in phase is called chloisma gravidarum. This is called chloisma gravidarum, which is also called melasma, which is also called pregnancy mark. The color is blackish brown pigmentation, more marked on cheek, nose, and forehead, and the reason is melanin. It is due to increased melanin. This is the change in face in pregnancy. What are the changes on breast in pregnancy? Changes on breast. Changes on breast in pregnancy. First of all, let's understand with the ray diagram. Just a ray diagram. This is breast, this is nipple. And what develops around breast? They develop another dark area. They develop another dark area around primary areola. This is the primary areola. This is the dark area around nipple. This is dark area. This is the primary areola. They develop another dark area. Around this primary areola, this is called secondary areola. This is secondary areola. What is this secondary areola? Write down another dark area around primary areola. It develops around 16 weeks of pregnancy. This secondary areola, this develops around 16 weeks of pregnancy. Another dark area around primary areola. What happens? There occur hypertrophy of sebaceous glands on primary areolar margin. Of course, they are at primary areolar margin. Secondary areola is just a virtual area. And these are called Montgomery tubercles. Montgomery tubercles are hypertrophied sebaceous glands at areolar margin. And why there occur hypertrophy of these sebaceous glands? Because of increase in basal metabolic rate. BMR increases in pregnancy. And because of increase in BMR, there occur hypertrophy of these sebaceous glands. Other changes in pregnancy are there occur increase in size. Increase in size is called mammogenesis. Why breasts are increased in size? Because of they are being prepared for lactation. Let me just show you another ray diagram. These are breasts. In breasts, there are acini and ducts. There are ducts and acini. These are ducts in breast, these are ducts. Just a ray diagram. Breast is not a gynae topic. Usually it is taught in surgery. So, these are ducts in breast. Ducts in breast. And this is acini or alveoli, like this here. We will label everything, don't worry. So let's label these. These are acini or alveoli in breast, and these are ducts in breast. Our exam question. This was asked in our exam 3 years before. And our exam question word by word was ductal growth in breast is due to what? They asked ducts grow in breast under influence of which hormone? So increase in size in breast, there occur ductal growth also, and there occur acinar growth also. Ductal growth in breast is due to estrogen, while acinar growth in breast is due to progesterone. Acinar growth or growth of alveoli in breast is due to progesterone. Our exam question 3 years before was ductal growth in breast is governed by what? Estrogen. This area is very important MCQ. One question was asked in June 22 FMG exam from this 4 lines only. I will tell you that. This is a 3 years before MCQ. Ductal growth in breast is governed by what? It is governed by estrogen. This collectively is called mammogenesis because in mammogenesis, that is increase in size of breast, there occur both ductal growth and acinar. If you get a question, mammogenesis is governed by, then answer will be estrogen and progesterone both. So one change was increase in size of breast, second change was formation of secondary areola, third change was development of Montgomery tubercles, and fourth change is, we know with our pediatrics knowledge, colostrum is the first food for newborn. It is very rich in nutrition, but its secretion starts on squeezing of breast after 12 weeks. It can be secreted on squeezing of breast after 12 weeks. So these are the 4 changes in breast. One is increase in size of breast, which is called mammogenesis, which is governed by estrogen and progesterone. Second is formation of secondary areola. Third is Montgomery tubercle, and fourth is colostrum. Let's have a look at this image also, and I hope you can easily tell what are these. These are Montgomery tubercles. Let's label this image. These are Montgomery tubercles, hypertrophied sebaceous gland at primary areolar margin. Montgomery tubercles. Fine. Now, what are the changes in abdomen? We have seen changes on face, we have seen changes on breast, now changes on abdomen. 2 types of line develop on abdomen. One variety of line is this, which is developing between pubic symphysis and xiphisternum. It is between pubic symphysis and xiphisternum, this line. This is a brownish black line which is extending between, this brownish black line which is extending between pubic symphysis and xiphisternum. This is called linea nigra. Why this is brownish black? This is due to increase in melanin. Brownish black line. This is linea nigra. Another variety of lines which develop in abdomen are, they are more in lower abdomen and upper thigh. These are pinkish red in color. They are curvilinear in appearance. What is the reason for formation of these lines in pregnancy? What is happening in pregnancy? Because of this fetus, there is stretching of abdominal wall. And because of stretching of abdominal wall, capillaries in abdominal wall are dilated. And because of dilatation of these capillaries in abdominal wall, there appear pinkish red lines which are called stria gravidarum. These are stria gravidarum. This was linea nigra, which is brownish black central line. These are stria gravidarum. And what will happen to these stria after delivery of baby? After delivery of baby, stretching of abdominal wall will disappear because fetus will be delivered. Because stretching of abdominal wall will disappear, these capillaries will be obliterated. So these lines will become white. So after delivery, these lines will become white. During delivery, they were pinkish white in color. During delivery, they were called stria gravidarum. After delivery, they will be called stria albicans. Alba means white. We remembered corpus albicans was white. So let's write down. These are the changes in abdomen. One variety of line, linea nigra, brownish black line. Brownish black line. Again, reminding you, I will post questions on Telegram. I will make the questions, many questions I will make now and will post at 9 p.m. Please do solve. We will discuss these questions in tomorrow's class. How and why did you commit silly mistake? That's exercise. Homework. Brownish black line, because we are not having a topic wise test for these sessions, so that's a good way to perform the test. Brownish black line between xiphis sternum and pubic symphysis. This is due to increase in melanin. These are called linea nigra. Another variety of line are stria gravidarum. These are curvilinear, more in lower abdomen and upper thigh, and they are due to dilatation. They are due to dilatation of capillaries in abdominal wall. After delivery of baby, these are called stria albicans. They become white due to obliteration of capillary. So after delivery of baby, these are called stria albicans. Then, what is the change in vagina? There are two changes in vagina. One is change in color. Other one is there is increase in number of Doderlein bacilli. Change in color. Color become bluish violet due to venous congestion. And this sign is called Jacomer or Chadwick sign. Second change, increase in number of Doderlein bacilli, because in pregnancy estrogen is increased. This increase in Doderlein bacilli is mainly due to increase in estrogen in pregnancy. Although progesterone is very high, but estrogen also increases. Doderlein bacilli convert glycogen to lactic acid. Because Doderlein bacilli increase in pregnancy, pH of vagina is most acidic in pregnancy, 3.5. In reproductive age, it is 4.5. When we will study our miscellaneous part after obstetrics, that we will cover in just 4 to 4.5 hours session, miscellaneous part. There everything is written. How much is the pH of vagina at various stages, how much is the size of uterus, cervix, everything. We have anatomy statistics, ovarian tumor, cancer vulva, metropathia hemorrhagica, types of hysterectomy, aneuploidy, antepartum, fetal well-being, biophysical score, amniocentesis, chorion villus sampling, short topics in a very sweet and short way. Complete miscellaneous part we will cover in just 4 to 4.5 hours session. So here we can stop it right now, and don't forget to solve the questions which I am going to post at 9 p.m. See you tomorrow. Bye-bye. Take care.